Good morning, good afternoon, and good evening. Your Excellencies, colleagues, ladies, and gentlemen, welcome back. We shall continue our consideration of sub item 14.1 COVID 19 response. I understand we have around 25 observers, intergovernmental organizations, and non state actors in official relations wishing to take the floor on this item. Please keep in mind the time limits for speakers. I shall now give the floor to the Secretariat to moderate the discussion on the virtual platform. Secretariat, you can have the floor, please.
Thank you, Your Excellency, Mr. Chair. May we kindly remind those observers, UN, IDO, and non-state actors who will be making a statement to please raise their hand in the Zoom platform. Continuing yesterday's proceedings, we understand the distinguished delegate of Palestine would wish to take the floor, to be followed by the representative from the Global Alliance for Vaccines and Immunization. Thank you, and Palestine, you have the floor.
Very good morning to everyone. I will speak in Arabic. شكرا السيد الرئيس. طاب يومكم السيد المدير العام لمنظمة الصحة العالمية مع وزراء.
Thank you very much indeed. Director General, dear colleagues, Your Excellencies, ladies and gentlemen, at the outset, allow me to thank the Director General for his presentation yesterday about efforts to combat COVID-19. He talked about the need to ensure that the vaccines are available to all, and it is a public good. I'd also like to thank the experts of WHO for their comments, and we support the statement made by the Sultan of Oman on behalf of our region. We pay tribute to the efforts of the Secretariat in spite of the difficulties and challenges that we're all facing, both developing countries and the poorest countries who are facing even greater challenges. It's very important that we continue to help all countries to get access to the vaccine. And that's why countries need to support the COVAX facility. We must support that facility and the ACT accelerator in order to guarantee the fair and transparent distribution and availability of vaccines. And that's why we need to support the 4 pillars of the ACT accelerator. It's also important to support the importance, to underscore the importance of partnerships and multilateralism in this context. We wish to thank the countries of the European Union, China, the Russian Federation, and all of the Arab countries who supported efforts in our country so that we can get access to diagnostics and therapeutics. We need to see more of such solidarity in order to support us and help us in our efforts against the occupying power Israel. We wish to pay tribute to the Director General of WHO, to all of the teams at WHO, Mr. Jaoud, who works with the Palestine office, and all of those who work in our regional office in Cairo. We thank them for their cooperation with the State of Palestine. Thank you.
Thank you very much. And we should now give the floor to the representative from the Global Alliance for Vaccines and Immunization. Gavi, you have the floor.
Thank you, Chair. With 190 participants representing nearly 90% of the global population, COVAX represents the only global solution and has been laying the groundwork for the equitable distribution and deployment of vaccines. By working with our partners, countries, and stakeholders, the COVAX facility has made agreements to secure over 2 billion doses of COVID-19 vaccines in 2021, enough to vaccinate 20% of the population of all participating economies that have elected to do so through COVAX. The agreements also ensure all participating economies can access doses in the first half of the year, prioritizing health workers and vulnerable groups in the initial rollout phase. As the rollout of COVID-19 vaccines picks up pace this year, Gavi and the COVAX partners, WHO and CEPI, will continue to work with our partners and countries to ensure their rapid and equitable deployment. To achieve this, the Alliance calls upon member states to first ensure COVID vaccines are allocated equitably and in line with SAGE allocation principles. Second, fully fund the COVAX AMC to at least US $7 billion to help ensure 92 lower income economies and territories can access vaccines on the same timely basis as wealthy countries. Thank you.
Thank you very much. I understand that a number of member states, EB members and member states not represented on the board, have raised their hand in the Zoom platform and should wish to take the floor. That being said, I should like to give the floor to the distinguished delegate of the United Arab Emirates, to be followed by Kazakhstan. Thank you, and you have the floor.
Thank you, Chair, for giving me the floor. I would like to thank the General Director on the comprehensive report and all the efforts exerted by the WHO in supporting the countries during the COVID pandemic. We are all deeply humbled by the sacrifice of all our frontline workers, volunteers, and all the community members, citizens, and residents alike for their efforts to overcome this pandemic while respecting country safety regulations. The political and high leadership engagement were an encouraging landmark in the country. The UAE government is committed to mitigate the effects of COVID-19 pandemic and protecting the rights of all people in the UAE, citizens, residents, and visitors. UAE has integrated state-level whole-of-government emergency system led by NCEMA, which is the National Crisis and Emergency Management Authority. This system is designed to have a high level of emergency preparedness and response for all types of emergency, including health. National Technical Advisory Team for COVID-19 pandemics with scientific research team were established with a multi-sectorial approach to assess the situation and recommend necessary measures on daily basis. UAE has adopted a strategy to strengthen the investigation examination procedure in the country and expand the scope of testing all over the country's level in detecting the new infection with emerging coronavirus with extreme national resilience. UAE government authorized the emergency use of COVID-19 vaccine and formed a national COVID-19 crisis recovery management and governance committee. UAE proud to host the Dubai International Humanitarian City as a hub of a global response with a collaboration with the WHO. The WHO weekly briefing and numerous COVID-19 items published throughout 2020 have been a great use and served as a clear kindness. Thank you, Chair.
Thank you very much. I should now like to give the floor to Kazakhstan, to be followed by El Salvador, before returning to those non-state actors in official relations with WHO to make their statements. Thank you very much. And Kazakhstan, you have the floor.
Chair, distinguished participants in the 148th session of the EB, allow me to begin by thanking the World Health Organization and its Director General, Dr. Tedros, as well as the regional directors for their leadership and their proactive support for the development of primary healthcare at global, regional, and country levels, despite the ongoing COVID-19 pandemic. In the midst of this pandemic, the COVID-19 pandemic, primary healthcare remains one of the key measures for responding and providing essential health services to our population. We think it is therefore very important to discuss all of these issues and to recognize the importance of the work done by Gavi in particular. Here we would also emphasize that we play an active part in seeking to develop vaccines against COVID-19. Let me remind you further that as things stand at present, we are working on developing and agreeing on an operational framework for primary health care. And indeed, this would build on what was previously adopted at the resumed 73rd session of the World Health Assembly. We therefore call for support for this initiative, and we do believe that we should support this operational framework and the 14 strategic and operational levers that have been determined. We believe this is particularly important because in this time of COVID, we must all recognize that PHC is the basic level of support for public health. While I have the floor, I would like to take this opportunity to ask WHO to support our initiative to hold a side event on this issue on the margins of the 74th session of the WHA in May 2021. And we would invite member states, international organizations, and others to participate actively in discussion of this operational framework for PHC. Thank you.
Thank you very much. And El Salvador, you have the floor.
Mr. Chair, thank you very much. Good morning, good afternoon, good evening. Greetings, Your Excellencies and Mr. Director General Dr. Tedros. El Salvador está trabajando de la mano de la Organización Mundial de la
El Salvador
Salud
is working closely with the WHO and with PAHO in all areas of response on which we've been working since the very beginning of this pandemic. El Salvador also has a national vaccination plan, and our national medicines regulatory authority has now authorized vaccines, including those pre-qualified by the WHO. We've worked closely with UNICEF, and we're now ready to begin vaccination rollout in our country. We are convinced that the COVAX facility is the right mechanism to ensure that countries can face this pandemic together. That's why, once again, we wish to reiterate El Salvador's commitment to the WHO, to PAHO, to UNICEF, and to the COVAX facility. Thank you very much for your attention. Thank you, Chair, and thank you, Director General.
Thank you very much. I understand that we have received a number of requests from non-state actors in official relations with WHO to speak under agenda item 14.1. The speakers list follows the order in which the statements were submitted to WHO. And now, with permission from the chair, I should like to call upon each of those non-state actors. If we could invite the World Medical Association, WMA, you have the floor.
Distinguished delegates, the WMA welcomes the report by the Director General providing an update on the Secretariat's activities to combat the COVID-19 pandemic. We take the measure of the very substantial charge to address this scourge and value the important efforts made on different fronts to provide a comprehensive and coordinated strategy to support member states, including the promotion of evidence-based information about COVID-19 to limit the spread of false information. We welcome multilateral solutions in the global battle against COVID-19 to ensure equitable global distribution of a safe and effective COVID-19 vaccine. No country should be left behind in the race to vaccinate its population against this global threat. We regret, however, that the report fails to address the adverse impact of the outbreak on health personnel in all regions of the world. Various concurred information attest of alarming increased acts of violence, threats, insults, stigmatization, undignified working conditions. Thousands of health personnel have already lost their lives. This is unacceptable. We call on WHO and member states to recognize the protection of health personnel from violence and discrimination as an international priority requiring urgent actions, including adequate accountability mechanism by governments against perpetrators of violence against health personnel, the recognition of COVID-19 as an occupational illness, providing compensation and other support to health personnel in case of infection, accurate and systematic data collection on violence incidents in relation to the pandemic to document the phenomenon, ensuring the security of the supply chain of personal protective equipment, as well as safe and effective vaccine for all health personnel on the front line. Protection and safe working conditions of health personnel constitute indispensable requirements of a solid health system. Member states are accountable for making this happen. Thank you.
Thank you very much. We truly value the comments by non-state actors. However, we would just wish to remind that the dedicated time is 1 minute. And that being said, we should now call upon the International Pharmaceutical Federation. Thank you. You have the floor.
Thank you, Chair. I'm speaking on behalf of the International Pharmaceutical Federation, FIP, which represents over 4 million pharmacists worldwide. With COVID-19 vaccines being given regulatory approval, it is vital for all countries to expand their vaccination pathways in order to deliver immunization coverage as quickly as possible. Pharmacists are an important part of robust vaccination strategies. In fact, in at least 36 countries, pharmacists already play an active role in administering vaccinations, with proposal or regulatory developments for vaccinations in pharmacies in further 16 countries. In light of the benefits to us all, FIP urges policymakers to enact the enabling legislation to allow pharmacists to prescribe and administer vaccines. Therefore, FIP calls on governments to enact the legislation necessary to support pharmacists in their contribution to bringing this pandemic to an end. Thank you very much.
Thank you. The World Obesity Federation.
Thank you very much. World Obesity Federation welcomes the report on the COVID-19 response. We commend the ongoing efforts by WHO and member states. In light of the evidence showing that obesity is one of the major pre-existing conditions that increases the risk of COVID-19 complications, we welcome obesity being recognized as a key independent risk factor for COVID-19 therapy. However, as a result of COVID-19 and the measures taken to curb the pandemic, we are seeing a detrimental impact on the provision of health services and care, including for people living with obesity. Too many obesity patients have sadly lost their lives to COVID-19. We are concerned that guidelines to ensure quality care around COVID-19 for people living with obesity remain absent. We are also concerned that COVID-19 is disrupting access to healthy diets and physical activity opportunities. Despite the proven links between obesity and COVID-19 mortality risk, there are possibilities that obesity rates, especially among children, may increase during the pandemic. We therefore call on member states to recognize obesity as a disease requiring urgent action, both in the short and long term. Ensure that responses to COVID-19 integrate prevention policies for obesity and other NCDs, including those which enable equitable access to nutritionally adequate food, support physical activity, and promote good mental health. Allocate health system resources to ensure appropriate care for people living with obesity who require COVID-19 treatment while ensuring access to routine services remain. Ensure that people living with obesity are consulted throughout the development of guidance and policies affecting their care. Ensure people living with obesity are included in COVID-19 treatment, research, vaccine rollout. And finally, support calls for a WHO resolution on obesity to ensure equitable global action on obesity, covering prevention, treatment, and management of the disease. Thank you very much.
The World Federation of Public Health Associations. Once more, we would wish to invite the World Federation of Public Health Associations.
Thank you, Chair, distinguished members, and non-state actors. The World Federation of Public Health Association, representing the global society, claims for equitable access to vaccine against COVID-19, to protect people's lives, and effective and safe COVID-19 immunization should be considered a global public good. And vaccine should be produced at larger volume, distributed equitably between countries, and provided at no cost for the user. Furthermore, without an equitable distribution of COVID-19 vaccine between countries, the world economy will not recover, causing greater human suffering and premature mortality. Unless government and the pharmaceutical industry take urgent action to ensure that enough COVID-19 vaccine doses are produced, 92 low and middle income countries will be able to vaccinate against COVID-19 only 1 in 5 people in 2021. On the other hand, high-income countries, which account for just 14% of the world population, have already purchased 48% of the 8.6 billion doses of the most promising vaccine. This can be achieved by waiving intellectual property rights to vaccine, tests, and treatment related to COVID-19, openly sharing the vaccine technology and intellectual property through the WHO, fully funding COVAX, stopping bilateral deals and investing in WHO efforts and in the strengthening of national health system. Given these facts, WFPHA respectfully asks the EB to take action to materialize what was proposed in Resolution WHA 73.1 COVID-19 response on global health and foreign policy. Both resolutions
with apologies, we would kindly ask that you conclude your statement. Yes. Thank you very much.
And WHO member states decided for equitable access to vaccine to face COVID-19. Thank you very much.
Thank you. And now to the United States Pharmacopeal Convention. Once more to the United States Pharmacopeal Convention. If I may propose that we would move to the next non-state actor, we would wish to call upon the United Nations Foundation. Thank you. And UNEF, you have the floor.
Thank you, Moderator. Honorable Chair, distinguished delegates, the COVID-19 pandemic has affected every person on the planet and has clearly demonstrated that global challenges require global solutions that are rooted in science and guided by solidarity. Early in the pandemic, the UN Foundation recognized the imperative of collective action and established the COVID-19 Solidarity Response Fund at the request of WHO and in partnership with the Swiss Philanthropy Foundation. Above and beyond the resources raised, $240 million and counting, the Solidarity Response Fund has been a tangible and amazing demonstration of global solidarity. The global community is at a fresh tipping point that will further test our ability to act in solidarity. How rapidly and equitably COVID-19 countermeasures can be accessed by all people everywhere. The ACT Accelerator is the only mechanism to ensure that COVID-19 countermeasures are rapidly and equitably available globally, which will be key to enabling all countries to transition out of the pandemic and restart domestic and global economies. It is a success of our test of collective moral leadership. Urgent financing for the ACT Accelerator must come from all donors, public, private, and philanthropic. Unless the funding gap is filled, many more lives will be lost and years of global development gains will be put further at risk. Thank you.
Thank you. The International Association for Hospice and Palliative Care.
So the aim of the palliative care is to relieve serious health-related suffering during COVID-19. COVID-19 has released a tsunami of severe health-related suffering that a palliative care component public health workforce could mitigate. Some member states are beginning to develop their workforce, building palliative care into their emergency response and preparedness plan, yet WHO report shows that existing services on ground level in most of the member states are inadequate both for COVID-19 response and for building back up better. We urge WHO member states to collaborate with palliative care organizations working on ground to relieve preventable suffering, particularly among older persons. Director General Tedros has stated that these partnerships should be strengthened, especially with regard to knowledge dissemination, capacity strengthening in the countries, and coordination between different levels of care. With regard to essential palliative care medicine in pandemic, we thank WHO for signing on to the joint statement for access to essential medicine in pandemic with INCB and UNODC in August 2020. Thank you very much.
Thank you. And now to the Global Health Council. Global Health Council, you have the floor. If I may, with apologies, please continue.
Sorry, moderator, it's the Task Force for Global Health. So thank you, Chair. Congratulations to the WHO and member states for their solidarity and shared effort in the face of the COVID pandemic. The Task Force for Global Health and its 17 programs partner with the WHO to build public health workforce capacity through its TEFINET program. TEFINET is the network of more than 75 field epidemiology training programs with over 34,000 alumni and over 4,700 trainees, forming a global cadre of well-trained field epidemiologists. To protect the health of all people from future pandemics and public health emergencies, it is critical to develop field epidemiology technical capacity. The task force, key partners and stakeholders met to develop effective global field epi capacity and developed a roadmap comprising 7 recommendations and a strategic leadership group. We urge you to support the work of the strategic leadership group to ensure that every country in the world has the necessary applied epidemiology capacities. Thank you very much.
Thank you. And now to the World Organization of Family Doctors. Wonka, you have the floor.
Opportunity to speak on behalf of the World Organization of Family Doctors, WONCA, representing 500,000 family doctors in 150 countries. Family doctors and their primary healthcare teams are central to health emergency risk management, preparedness, and communication locally and nationally. We urge member states to involve family doctors in each community's planning of the pandemic response, including vaccine access and distribution, and in the design of primary healthcare strategies to approach the present and future crises and pandemics. Family doctors have vital roles as trusted members of the community and in the front line of health systems. Their roles include risk assessment, emergency care, disaster prevention, preparedness with vaccinations and risk communication and response, and on the follow-up during recovery and rehabilitation, reducing the exacerbation of chronic illnesses. To achieve a high-quality emergency response, primary health care needs to be appropriately funded with an investment in human resources for health, with training and improved working conditions, including provision of personal protective equipment and vaccinations for all members of the primary healthcare team. The primary healthcare workforce should be in numbers sufficient to meet each country's needs and with educational and skill training to provide the complexity of care required in emergencies, often managed by primary healthcare teams. WONCA is committed to the emergency response in the collaboration with WHO regions through WONCA regional organizations, and with member states through national associations of family doctors. Global and member state collaboration with experts in family medicine will enhance the preparedness of primary health care during the pandemic and future emergencies. Thank you very much.
Thank you. And now to Knowledge Ecology International.
Thank you, Chair. Knowledge Ecology International asks the WHO to exert greater leadership in measures to scale production, increase competition, and speed the delivery of vaccines, therapeutics, and other technologies in the COVID-19 response. WHO's COVID-19 Technology Access Pool, CTAP, should publish agreements for the sharing of rights in inventions, data, biological resources, and know-how, including specifically the components of full technology transfer that CTAP is seeking for each relevant technology. WHO should publish a report on global manufacturing capacity for each relevant 19 medical technology, including each type of COVID-19 vaccine, with commentary on measures necessary to bring facilities into GMP compliance for specific vaccines and other relevant technologies. WHO should commit to full transparency of all technology transfer agreements with rights holders and licensees. For CTAP to succeed, WHO needs to hold bi-weekly public briefings where news media can hold the Secretariat, member states, manufacturers, and right holders accountable. Thank you, Chair.
Thank you. And now to Stichting Health Action International.
On the report of the Director General on the COVID-19 response. We commend how WHO has been attempting to coordinate global efforts to confront this deadly pandemic, despite the lack of resources and, in some cases, the depth of collaboration from member states. Initiatives like the Solidarity Therapeutics Trial stand out as a milestone in global health promotion, which provided key information in the early stages of the WHO has also joined efforts with other organizations and stakeholders, but on occasion have ceded leadership and initiative to actors not as committed to transparency or civil society participation. While any global attempt to secure universal and equitable access to vaccines should be supported, it is concerning that contribution and expertise from public interest NGOs, especially those based in low and middle income countries, is not considered relevant. We are surprised that the document fails to acknowledge the COVID-19 Technologies Access Pool, CITA, a platform which, by gathering and channeling IP, know-how, and other relevant data, could play a critical role in transferring technology and scaling up production of vaccines, diagnostics, and other health goods necessary to vanquish this pandemic. Finally, the fact that wealthier countries, some of them sitting at this executive board, are hoarding vaccine doses, while other countries are unable to procure treatments for their vulnerable groups or healthcare workers, is shameful. And WHO should be more vocal in announcing the exclusive deals that are weakening us all. Thank you.
Thank you. And now to the International Federation of Medical Students Associations.
Honorable Chairperson, distinguished delegates, the COVID-19 pandemic has shown that the resilient health systems, preparedness for health emergencies, and multilateral collaboration are pivotal for achieving WHO's mission and preserving its essential role in global health leadership. The International Federation of Medical Students Associations, supported by the International Veterinary Students Association, commends and recognizes the efforts invested by the WHO in creating perhaps the most complex health response in history. We call upon member states to work in solidarity and partnership with the WHO to ensure a global response that strives for health equity, focusing on research mobilization for universal health coverage as the key for health security, based on joint and evidence-based decision-making. Now is the moment where trusting WHO's governance and leadership is crucial for building back better, stronger, and in solidarity. Thank you.
The International Federation of Pharmaceutical Manufacturers and Associations. IFPMA, you have the floor. Okay, we shall move to the European Society for Medical Oncology. You have the floor.
Honorable Chair, esteemed delegates, the European Society for Medical Oncology, ESMO, is a global network of more than 25,000 cancer professionals from over 160 countries. We call on WHO and member states to ensure essential health and cancer services and to make the protection of cancer patients through immunization against COVID-19 a public health priority. ESMO has launched a call to action on COVID-19 vaccinations in patients with cancer, endorsed to date by over 40 organizations. We request member states to consider in their COVID-19 vaccination strategies to, 1, vaccinate all cancer patients, in line with WHO principles aiming to reduce deaths and disease burden. Patients with active disease or receiving anti-cancer treatment deserve an additional priority in case of limitations only. 2, to diligently collect and monitor data via suitable registries and studies. And 3, to educate and instill confidence among the public and patients in receiving the vaccines. ESMO has also published statements on concerns about immunizing patients with cancer against COVID-19, and we have a COVID-19 and cancer portal available at www.esmo.org. Thank you.
Thank you. The Worldwide Hospice Palliative Care Alliance, you have the floor. The Worldwide Hospice Palliative Care Alliance, the WHPCA, you have the floor. And it seems we're unable to connect. If I may suggest, we move to the International Council of Nurses. ICN, you have the floor.
Okay. International Council of Nurses' latest report shows that in every region of the world, nurses are experiencing mass traumatization and mental distress. More than 1.6 million health workers have been infected and more than 2,000 nurses have died. The pandemic has the potential to devastate the nursing workforce. The COVID effect could cause the current expected nursing shortage to increase from 10 million to a number nearly half the size of the current nursing workforce. The shortages will severely impact countries' ability to deliver healthcare to population. ICN has suggested government to create health education and retraining opportunity or hero funds to support people who have lost their jobs in some sector to retrain to join the health workforce. ASEAN encourages member states to establish this fund and to prioritize health education in recovery plans. Lastly, adequate reporting mechanisms are not in place in many countries, or the data is not publicly available. Comparable country data is essential to track the impact on health workforce and monitor the COVID-19 response. Thank you so much.
Thank you. And now to Handicap International Federation.
The COVID-19 outbreak shows the need to integrate rehabilitation in health systems in line with WHO Rehabilitation 2030 initiative. Rehabilitation is an important health strategy for persons affected by COVID-19, as well as for many persons experiencing loss of function and disability due to other conditions. Rehabilitation is crucial to address the needs of people with severe COVID-19 during the acute phase, the subacute phase, and all over the long-term recovery. This outbreak forces decisions about which essential services should remain operating, including rehabilitation services, which have experienced significant disruption. Handicap International Federation, supported by many members of the Global Rehabilitation Alliance, urges states to 1. Incorporate rehabilitation in health planning in relation to both the rehabilitation needs of people affected by COVID-19 and other groups requiring access to rehabilitation. Second, maintain early rehabilitation care for injured people or with newly acquired impairments in strict compliance with prevention measures in place. And third, provide access to telerehabilitation as a crucial modality to continue providing an essential health service like rehabilitation for those who need it. Thank you very much.
Thank you very much. And just before we take the final three statements from non-state actors in official relations, we understand one of the intergovernmental organizations, the International Atomic Energy Agency, would also wish to make a statement under this item. You have the floor.
Thank you very much, Chair. The COVID-19 pandemic has highlighted the critical importance of international cooperation during a global crisis. Since March 2020, the IAEA has contributed to strengthening the global response to COVID-19 by providing equipment and training on diagnostic techniques. We have a long-standing record of developing and deploying nuclear and related techniques for rapid and accurate detection of animal zoonotic diseases such as COVID-19, avian influenza, Ebola, and Zika. The IAEA has built member state capacities in using real-time diagnostic machines. Today, the agency is delivering support to 285 designated national laboratories in 127 countries and territories around the world to tackle the pandemic. These supports include provision of RT-PCR machines, kits, consumable equipment for sampling, testing and control, as well as training through webinars, educational videos, and one-to-one laboratory support. Collaboration with the WHO has been essential to reach more than 4,000 professionals from labs globally. The documentation regarding the IAEA assistance on COVID-19 response has been submitted to the Independent Panel on Pandemic Preparedness and Response. As a member of the WHO-led COVID-19 UN Crisis Management Team, the IAEA continues cooperating with WHO and FAO, and we look forward to continuing our collaboration. Our extended statement under this agenda item will be made available to the Executive Board portal. Thank you very much, Chair.
Thank you very much. And now to Public Services International. PSI, you have the floor.
We commend WHO's central role in the pandemic response. More needs to be done by governments within the multilateral system. As resolved by the 73rd World Health Assembly, we need transparent, equitable, and timely access to quality, safe, and efficacious diagnostics, therapeutics, medicines, and vaccines globally. Inequitable access to COVID-19 vaccines is morally indefensible and practically short-sighted. We must all put health before wealth. The vaccines are global public goods with public funding enabling their development. We thus call on member states to ensure waiver of intellectual property rights to enable upscaling of COVID-19 vaccines and other technologies production. This is a time for global solidarity. We urge member states' commitment to guarantee COVID-19 vaccines are made free and available to everybody. And to give meaning to 2021 as the International Year of Health and Care Workers, we call on member states to prioritize recruitment, training, decent work, and workplace safety of health workers. Thank you.
Thank you. And now to the Union for International Cancer Control, UICC, you have the floor.
Distinguished delegates, we appreciate the opportunity to speak on behalf of UICC, supported by the NCD Alliance. Non-communicable diseases have been systematically overlooked in preparedness planning and in the response to COVID-19. Regarding the work of the independent panel, we call for an assessment of how the reliability of the Global Health Security Index would be improved by considering prevalence of NCDs and risk factors. Services for NCDs and mental health have been disrupted in far more countries than other services. As a result, the toll of NCD deaths during and after the pandemic will likely be significantly higher than COVID-19 itself, driven by disruptions in diagnosis and treatment. This must not be an either-or decision. Prevention of NCDs and ensuring continuity of essential health services must become a part of emergency preparedness and seen as an investment in resilience. People living with NCDs, almost a quarter of the global population, are at higher risk in health emergencies, but are being left behind. We cannot achieve the strategic priority of 1 billion people better protected from health emergencies if you do not act on NCDs. Thank you very much, Chair.
Thank you very much. And now to our final statement by non-state actors in official relations. We should wish to call upon Medicus Mundi International, the Network Health for All. MMI, you have the floor.
Thank you. This MMI statement is supported by PHM. Binding technology and knowledge sharing commitments would be more effective in meeting the unprecedented demands we are facing. Initiatives like the ACT Accelerator have already shown the loss of the multi-stakeholder approach, where only a few member states and donors take crucial decisions. WHO must work to improve solidarity and equity in the delivery of and the access to vaccines and medical products. Vaccine nationalism has undermined international cooperation, with a number of high and middle-income countries striking bilateral deals with manufacturers. The COVAX facility has failed to solve that. We call for WHO to strengthen the CTAP initiative by including binding commitments based on the principle of access and benefit sharing. The TRIPS waiver proposal is critical for scaling up global production of COVID-19 technologies. We welcome WHO support for the waiver and urge member states to extend their support as well. Thank you very much.
Thank you very much indeed. And we shall now hand back to His Excellency, Mr. Chair.
Thank you. If there are no more requests for the floor, I shall ask the Secretariat to respond. Secretariat, you can have the floor again.
Thank you very much, Mr. Chair. We understand that two of our regional directors should wish to come in on this agenda item. That being said, we would have the pleasure of handing the floor to the Regional Director for the Americas. Dr. Etienne, you have the floor.
President, Honorable Ministers of Health, distinguished representatives, DG and colleagues. Indeed, as many of you have noted, we are facing the biggest global public health challenge in a century. And The Americas has been at the epicenter of the pandemic for a substantial period, and our member states have been working tirelessly in responding to these challenges and getting ready for the COVID-19 vaccine. Nevertheless, as you have also heard, the cases and deaths continue to increase unrelentingly, overwhelming health services in many countries of the region. PAHO's genomics surveillance network of 21 laboratories has been tracking the spread of the virus and mutations. The variants previously identified and circulating in other regions have been reported in Brazil, Canada, Chile, Ecuador, Jamaica, Mexico, Peru, and the United States of America, and new local variants have been identified in Brazil. We are grateful to all our partners who have made it possible for us to assist countries in the Americas as they take on this deadly pandemic. With these contributions, PAHO was able to give technical cooperation to many countries, purchasing of essential supplies and equipment, including 119 shipments of personal protective equipment to 34 countries and territories, 21.4 million COVID-19 PCR tests for 36 countries and territories, and more than 224 trainings on testing, tracking, and patient care were held. As a key component of its technical guidance to countries, PAHO disseminated some 111 guidelines and recommendations. Together, we have learned a lot about COVID-19, but the most important lessons come from the countries themselves, those who are at the forefront of the response, and who are dealing with the multiple technical, social, political, and economic challenges. So let me take this opportunity to recognize the ministers of health who have shared specific aspects of their national and local work. I need to reiterate in the words of our Director General that our public health response to the disease must leave no one behind, and we will not relent until everyone is safe globally. Over. Thank you.
Thank you very much indeed. And we would now wish to invite the Regional Director for the Eastern Mediterranean to kindly come in. Dr. El Mandari, you have the floor.
Thank you very much. Mr. Chair, Excellencies, Director General, ladies and gentlemen, the year 2020 provided us with opportunities to transform the way we work at both regional and country levels, as well as with our partners and national counterparts, to demonstrate high-level support and sustain collaboration across all areas. Meetings of the regional multidisciplinary incident management support team for COVID-19 are attended every day by myself and by my senior management team and colleagues. I also continue to engage daily and directly with ministers of health and other regional leaders and counterparts here in the region and beyond. Multi-sectoral support mechanisms led by the highest level of government were established by most member states to coordinate COVID-19 response activities across the region and to promote strong partnership with communities and the private sector. Mr. Chair, Your Excellencies, ladies and gentlemen, we continue to enhance preparedness and response capacities across the region, including working to combat misinformation and rumors and to address COVID-19 fatigue. In 2020, teams of the public health experts from the regional office conducted 12 country missions to support the response on the ground. Across the region, testing capacity for COVID-19 was expanded. ICU and critical care capacities were strengthened, and infection prevention and control practices were improved. We also worked to scale up essential health services in all countries to avert excess, morbidity, and mortality from other causes. Our logistic hub in Dubai proved instrumental in the response, arranging over 400 air shipments to 110 countries across all 6 WHO regions. In spite of this collective progress, we still have much work to do. And while COVID-19 remains our top priority, we continue to respond to many other acute and protracted emergencies in the region. This year, more than 100 million people will require humanitarian assistance across our region, where we currently responding to 9 large-scale humanitarian crises that also require our full engagement. We must continue our life-saving work in these settings, expand access to essential health services, rebuild health systems, and advance health security. Our regional vision, Health for All by All, requires that we build on the solidarity and action seen in 2020 so that we can successfully realize the right to health, especially for the most vulnerable groups. I thank you, Mr. Chairman.
Thank you very much. And now to the Regional Director for Europe, Dr. Kluge, you have the floor.
Dear Mr. Chair, Dr. Harsh Vardhan, Director General, honorable members of the Executive Board and colleagues. The 24th of January will mark 1 year since the first cases of COVID-19 were reported in the WHO European region. Since then, sadly, 650,000 Europeans have lost their lives to the virus. The approach that we at the regional office have taken to prepare for and respond to this devastating pandemic is based on the principles underpinning the European Programme of Work, United Action for Better Health. First, through partnership with the European Commission and European Union, but also with the Council of Commonwealth of Independent States, the Eurasia Economic Union, the Turkic Council, the United Nations, and many others. Second, a country focus, anticipating and responding to the request of the member states whenever they arise, and working together to deliver actionable policy guidance. And third, through a WHO fit for purpose, placing equity and the most vulnerable at the forefront of our work and reinforcing the leadership of health authorities. We have striven to create open dialogue with every single member state, policymaker, health professional and citizen, providing access to the latest verified information and platforms to share experiences and learning. Our country offices have been critical for this outreach, and I would like to salute our WHO representatives. Interesting, while many member states appreciated the software, they were also appreciative for WHO delivering hardware, procurement when no one else did. An important role of the regional office was to bring science and policy through the political lens at the country level, so that we could offer contextualized, implementable recommendations, be it on school reopening, maintaining essential health services, pandemic fatigue, seasonal influenza, or as we do now, on travel movements in the region. As we enter 2021, we see 3 priorities. The first one is equal access to COVID-19 vaccine and vaccination, and avoid that geopolitical tensions will rise because of this, through a combination of solidarity and pragmatism. The second is to scale up our dual-track health systems, be it on control of cancer, HIV/TB, AMR or other ones. And third is about the longer-term effects of the pandemic through the Monti Commission, the Pan-European Commission on Health and Sustainable Development, to rethink policy priorities in the light of pandemics. I would like to thank you, the member states and the partners, for our collaboration, the trust we got in there together, and I'm sure soon we'll get out of there together. Thank you.
Thank you very much to Regional Directors AMRO, EMRO and Euro for these very, very helpful inputs. I understand that the rest of the Secretariat response will be coordinated by Dr. Mike Ryan. That being said, I have the pleasure of handing Dr. Ryan the floor. Thank you.
Good morning, everybody.
We would like to thank the EB members, the member states, the observers, and others for your encouraging statements regarding the ongoing operational, technical, and scientific work being coordinated between WHO and its partners around the world, most importantly, yourselves. There were a number of specific issues raised. I think they will focus, many of them focused on the vaccination issue, so I'll hand to Bruce to deal with that. And I will hand to Maria Van Kerkhoff to give you some information on the follow-up on the variants and the risk monitoring framework, and to my colleague Jawad Majur for matters related to IHR. One specific issue that was raised, I think, by our colleagues in Australia, and thank you for your comment. You raised the issue of the importance of surveillance and monitoring before and during the pandemic, and absolutely the ability to create actionable insights from data. Public health intelligence as such is a cornerstone of public health practice, and it's a foundation for effective emergency preparedness and response. High quality, accessible, timely and reliable data across multiple sectors is crucial for decision making before, during and after emergencies. Under the leadership of WHO, of Dr. Tedros, WHO has begun laying the foundations of that since he took office in 2017. I do recall my first meeting with Dr. Tedros, where he said, build me a dashboard, I need to see where these diseases are. We built that dashboard in 12 weeks, and we've evolved it ever since. The senior management of this organization has instant access to all the information that the Secretariat holds in real time and visually through multiple platforms. But that wasn't adequate. We, in October 2017, working with many of you and with the joint research unit of the European Commission, began developing the Epidemic Intelligence from Open Sources platform. And that really provides the first step in developing a global ecosystem, a data architecture for monitoring these events, detecting them, and monitoring the impact of our control measures. We have developed further the EIOS initiative. We've developed the Go Data initiative for field-based data capture, the emergency management and response system, which we use within our house at all levels for the management of response, and implements our emergency response framework. And EMRS 2 is currently been developed and will have applications that will be available to member states. Those member states who wish to implement a version of our EMRS 2 will be free to do so, and we will support that implementation. We fundamentally believe that data-based surveillance, data-based decision-making, and evidence-based decision-making is the way forward. And this organization has been laser-focused on trying to develop those systems. We thank the government of Germany particularly for their support in developing these systems. There are many others around the world. And we're labeling the overall approach here as the EpiBrain initiative. We do need to move forward on the systems, and under the leadership of Dr. Tedros, we have been pushed to do that. But I would say that the resources to achieve this are great, and as spoken by many member states, the Secretariat is constantly constrained by a lack of the appropriate resources to develop these 21st century solutions. With that, I will hand over to Maria Van Kerkhoff. Maria, if you could just update the member states on the China mission and on the risk monitoring framework for the variants.
Thanks, Mike. Yeah, so very briefly, the China mission is underway, as you all know. The team is still in quarantine and is working with their Chinese counterparts over video conference. Things are progressing nicely and the studies are underway. As you know, there are a number of studies that are currently being undertaken with the earliest cases in Wuhan, and the team is having detailed discussions about the results of those studies. There will be more studies as we learn more from in the first round of studies, as we call phase 1, that will lead to phase 2 studies. So the team is progressing nicely, and once they finish their quarantine period, they will have face-to-face meetings and have a number of visits in China. Just briefly on the risk monitoring framework, thank you for mention of that in your statements. So WHO is establishing a risk monitoring framework to evaluate SARS-CoV-2 mutations and variants across the world. There are several components of this framework, and we are very grateful for all of the work of the member states to enhance this. And we thank your support for enhancing this. First of which starts with enhancing epidemiologic surveillance, making sure that we have good, robust molecular testing. We utilize rapid diagnostics around the world that are becoming available and that are performing well, and making sure that we enhance our genomic sequencing capacities. You heard a great example from PAHO. We have several of these networks around the world, including AFRO and EMRO. And so we do need to expand that, leveraging existing systems such as the global influenza laboratory systems, as well as others such as polio, for example. But we need to share those sequences and the metadata so that phylogenetic analysis and bioinformatics can also be increased. We are working to coordinate the research studies on the potential variants of interest as well as the variants of concern. These include protein modeling studies, in vivo and in vitro laboratory studies, modeling and epidemiologic studies, and making sure that we have a proper evaluation of the impact of potential impact on diagnostics, therapeutics, and vaccines. All of this information needs to be coordinated across the world. We're doing this through our Virus Evolution Working Group, as well as our Research and Development for Epidemics, our R&D blueprint for epidemics. All of the information that is generated through this risk monitoring framework is used in our WHO rapid risk assessments, which are conducted regularly by the organization. Thank you very much for your work in expanding genomic sequencing, because we do need better eyes and ears on looking for these variants of interest, as well as these variants of concern.
Yeah, thank you, Maria. And now we will pass to Dr. Jawad Mansour.
Thank you, Mike. Thank you very much. Just a quick update on the health measures in relation to the international travel, because several member states raised this issue in their statement. As you know, the last month, WHO published a set of consideration for implementing a risk-based approach to international travel in the context of COVID-19 and an accompanying operational risk assessment tool. This guidance aims to support countries to apply risk management approach in the gradual resumptions of international travel, with the main objective of reducing travel-associated exportation, importation, and onward transmission of SARS-CoV-2, while avoiding unnecessary interference with the international traffic as per of the purpose and scope of the IHR 2005. Last week, the Director General accepted the advice of the IHR Emergency Committee and issued a set of temporary recommendations to state party under the IHR. I will just highlight two of them who are related to the health measures in relation with international travel. The first one is to implement coordinated, time-limited, risk-based and evidence-based approach for health measures in relation to international traffic in line with WHO guidance and IHR provision, with careful consideration should be given to when and if travel ban should or should not be used as a tool to reduce spread. Such decisions should be based on the best available evidence. The second one, which is extremely important, says, and I quote, at the present time, do not introduce requirement of proof of vaccination or immunity for international travel as a condition of entry, there are still critical unknowns regarding the efficacy of vaccination in reducing transmission and limited availability of vaccine. As advised by the IHR Emergency Committee, we will continue to lead to development of risk-based international standards and guidance for reducing SARS-CoV-2 transmission related to international travel based on current scientific and good practices, and we'll also develop and disseminate our position on legal, ethical, scientific and technical consideration related to requirement of proof of COVID-19 vaccination for international travel in accordance with the relevant article in the IHR provision. Thank you very much. Back to you, Mike.
Thank you, Jawad. And I forgot one point that was made by our colleagues at the World Medical Association. I think it's exceptionally important, and that is the security and protection, especially of frontline health workers, and by extension, those who are most potentially exposed or vulnerable in our communities, particularly those people living in fragile and conflict and vulnerable situations. So I will just ask my colleague, Dr. Behemoth Sosek Fall, just to give you a very brief update on how we're working with our humanitarian agencies, rights agencies, and also working to monitor the impact in terms of attacks on healthcare everywhere. Sosek?
Thank you, Mike. Good morning, Your Excellencies, colleagues. And as you rightly said, and highlighted by Dr. Tedros many times, WHO remained highly concerned about the inequity in distribution of COVID-19 vaccine globally, but especially in low and middle income countries and humanitarian settings. That's why since the beginning of the pandemic, we have been working very closely with humanitarian partners to develop the global humanitarian response plan, targeting 63 countries worldwide. And specifically for the COVID vaccine, we have been working on what we call the COVID-19 vaccine humanitarian buffer to concretize the commitment of WHO and partners in access to COVID-19 tools, accelerator and fair allocation mechanism for COVID-19 vaccine. But the number one principle is really for national government, they are responsible and accountable for the health of and vaccination of all people living within their borders, regardless of their residency and legal status. So WHO, together with ISC principals and COVAX partners, are working strongly to advocate for inclusion of such group in national vaccination plan. So the scope of the COVID-19 vaccine humanitarian buffer is to enable allocation and distribution of up to 5% of advanced market commitment funding for vaccine through the COVAX facility to a defined set of individual and population left behind by national-led processes in humanitarian context. Clearly, we need also to prioritize all frontline workers working in humanitarian setting. It can be specific health workers or people facilitating work and access to the most vulnerable population. So we continue working with Gavi in one side and COVAX partner, but also with the IC principle to make sure that this population are not left behind. Thank you.
Thank you, Sosek. And with that, I'll pass to my colleague, Dr. Bruce Elwood, who will introduce a couple of other colleagues regarding COVAX and the ACT Accelerator.
Thank you very much, Mike, Mr. President, members of the Executive Board, member states, and colleagues. First, I'd like to just thank and recognize our member states for so many comments recognizing the crucial role of the ACT Accelerator in supporting the response, as Mike has outlined. And also, we appreciated the emphasis across all three lines of defense. There's so much attention right now on vaccines and accelerating their rollout. It's important to remember that will be our first line of defense to help prevent infection. We need the second line of defense, the new diagnostics scaled up to detect and guide the isolation and quarantine. And then we need the third line of defense to be able to treat those who are infected and to save lives, all underpinned by a system that can deliver these and by the equitable allocation guidance. As so much of the comments, Mr. Chair, focused on the specifics of COVAX at this time, we're going to focus our particular comments on that. Dr. Swaminathan will say a few words about some of the outstanding science issues that were raised and the emerging variants. Dr. Simao on the equitable allocation of regulatory points, and then Dr. Kate O'Brien, the head of our vaccines department, on some of the questions about specific support to country readiness. And then I'll wrap up with just a couple of points on what we're doing to enhance the communications and the information member states need going forward to plan their rollout. So Dr. Swaminathan, our chief scientist, will comment first.
Thank you. Thank you, Bruce. Your Excellencies, first of all, I'd like to thank all the member states who not only expressed their appreciation, but have been providing support for all the normative and scientific and technical work that's been going on over the past years. And we have experts from many, many different countries who work together to produce not only the guidance documents, but also on the research side. As you're aware, we hosted the first global forum for research and development under the framework, the R&D Blueprint framework, in February of 2020. which resulted in a research roadmap that outlined the key priorities. And since then, we've had 9 working groups working on areas from epidemiology and transmission of the virus to infection prevention and control to social and behavioral science and research on diagnostics, therapeutics, and vaccines. Maria mentioned the meetings we had last week. One focused on the new variants that are being increasingly identified, and the other one on vaccine research, because we are in a different position in 2021. The overarching recommendations from those meetings, which actually brought together thousands of experts from around the world on the virtual platform, were that WHO should continue to lead in this area, should provide the platform for sharing of knowledge, sharing of research. And I'm happy to say, as an example of our clinical data platform, now currently hosts data from 78,000 individual patients with COVID-19 from 45 countries. This obviously is a resource that feeds into the guidance that we do and helps us to learn more about the disease. But this is where I think we need member states to really share data much more in real time as it's available. We have a clinical data platform for clinical data. We have the lab networks mentioned by Mike and Maria. We have the GISAID platform for genomic sequence data and the CTAP that Dr. Samau will talk about, as well as the BioHub that the DG mentioned in his speech, which provides a mechanism for countries to share samples and specimens from patients. It's important to continue with research and clinical trials on vaccines as well as on therapeutics, because we still have the need for many more products. We still need to have a drug that really works against this virus. We still need vaccines that are not only safe and efficacious and can work with a single dose, but can work across different populations, are affordable and easy to scale. So it's really important that while the first few vaccines are getting rolled out in countries, that we don't take the eye off the 65 other vaccines that are in clinical development today and the over 150 in the preclinical stage. So we will continue to work with our partners, with, of course, CEPI and Gavi in the COVAX, but also with experts from all the member states to advance this area of work. And with that, I'll turn it over to Dr. Samau.
Thank you, Dr. Swaminathan, and thank member states and other non-state actors for the statements in support of equitable access. Let me start with the allocation mechanism, because we have been discussing, last year we have discussed with member states on several occasions the framework, and then now we do have the mechanism in place, and we have run the mechanism, you know, we are preparing for both vaccines and therapeutics. The vaccines arm is ready to go. We did do a dry run in December, so we know what adjustments needed to be made. And let me stress again that the allocation mechanism is it's a joint Gavi, WHO, and CEPI work, and it's the backbone of equitable access, because it will process all the doses and will ultimately provide a proposal for the distribution of the different vaccines across the member states who have joined COVAX. So we are ready it's ready to be operationalized, and we are very happy to do a more in-depth briefing to member states as soon next week or the week after as needed. We are very happy to do that. Let me say that as part of the allocation mechanism, we do have an independent assessment for a vaccines group, and we did discuss this at the last member state briefing. We received more than 140 nominations. We should have the selection ready by the end of this week, and the independent assessment group working by the end of this month. The second topic is just a few informations on the emergency use listing process in WHO, at which stage we are right now. And let me say there is a link in the WHO COVID page you can find a link to a weekly updated for more details about the EOL process, where each producer is at this stage, and it's updated every week. You know, we have the Pfizer listed, and we have full dossiers from 3 other companies right now: Sinopharm, Sinovac, and the Serum Institute of India. They are under assessment. The inspections, we have a mission in China right now to do the inspections in Sinopharm and Sinovac. So these are the dossiers, the full dossiers we have with us. We have received the core data from AstraZeneca, which was already assessed. You know that AstraZeneca has 8 different sites of manufacturing. So we are expecting to get more information from AstraZeneca SK Bio, which is the site in Korea, in the Republic of Korea, by the end of this month. And we're working very much in a very collaborative way with the National Regulatory Authority in the Republic of Korea. So we are still waiting for additional information from AstraZeneca SK Bio. For Russia, we're still waiting for additional information from Gamaleya. We have a meeting next week where we expect that more data will be brought to the team for us to be able to process the request for an emergency use listing. On the third point related to CETAP, and let me say that the management of intellectual property is always a sensitive issue, and it always comes up whenever we discuss access to medicines, vaccines, health products, right? And in the midst of a crisis, it's no surprise that it comes up again. So we welcome very much the statement of support to CETAP, which is the platform that's being run by WHO with other partners, to voluntary sharing of knowledge and licensing of IP through the medicines patent pool. And that includes, I think, several countries mentioned the need to increase technology transfer. So we believe that CETAP is the right platform to pull in the knowledge and help the processes towards technology transfer to become a reality. At this stage, we need to strengthen engagement from both governments and from industry. And here I'd like to say that we did 2 consultations with the private sector recently in December and January, and I'd like to here publicly say that we received support not only from Costa Rica and other countries who have signed the Solidarity Call for Action in May, but also from the UK government, who hosted a consultation with private sector in the UK in December. We are very grateful for this opening. We'll keep member states updated on CETAP, on the next steps taken and the way forward. We did have a member state briefing in, I think, in November on this. We are also stand ready to do an update session. Thank you very much.
I'd like to, thanks Mariangela for all of that update on the regulatory and other aspects. I'd like to address the questions on country deployment and rollout and the support to countries for assuring that it's not just that we have vaccines, but that we actually have vaccination taking place in all countries. Very much heard the concerns about support to countries, especially those that have weaknesses in parts of the system that would allow as rapid as possible deployment of vaccines. And I'd like to address the response and support from WHO that really is centered on supporting all countries for the components of the vaccination program that is required in order to deploy and roll out. So this, of course, is critical at the country level, especially with our country offices and the WRs who are fully engaged with each country in all aspects of what is needed, and through the regional offices and regional directors for each region where there are a range of issues that need to be addressed, primarily these issues around vaccine access and the components of readiness. The aspects that WHO is fully undertaking are in collaboration and coordination with UNICEF, with Gavi, with NGOs, with the World Bank, because this is really going to take in all countries a sort of whole of community and whole of government and whole of organizational approach. We are providing guidance and trainings and tools and materials and direct technical support in countries for these critical aspects that are needed in order to roll out. So beyond what was just described around the regulatory issues are also issues around legal requirements, indemnification, the cold chain, of course, the development of a policy of who will primarily get vaccinated in the very first early wave with limited numbers of doses. Communication and hesitancy was specifically commented on in the comments from member states, and the provision of ways to address this and ways to address misinformation with a variety of interventions that we've developed and data collection in countries because of how tailored this needs to be country by country. We have simulation exercises that have been stood up now on vaccination rollout, specifically on the regulatory and safety components, and another focused on vaccination strategies and communication and the supply and logistics of vaccine. We also have training modules and have trained over 25,000 individuals around the world on vaccine rollout. And we're engaging with social media companies to address the misinformation, conspiracy theories, and the other issues that are being sort of propelled through social media that are threats to a vaccination rollout. I want to also mention innovations. And as we're in this remarkable phase of trying to initiate vaccination rollout in all countries, there are a number of areas where we're promoting innovation that includes vaccination certificates, not for the purpose, as was described earlier, for international travel, but for documentation of individual vaccination status, for program monitoring, and for individuals' awareness. And then as well, vaccination barcodes, vaccine barcodes for tracking and tracing, as well as the use of electronic monitoring of doses. Again, critical nature of the rollout monitoring so that course corrections can take place in every country, as we've seen the programs initiate, and those course corrections are needed. And so I'll just comment also that we are setting up a learning platform for sharing of what the roadblocks have been in countries, are being seen in countries, and what the solutions are to overcome those roadblocks, so that as the experience comes through with ever increasing numbers of countries in the coming weeks and early months, that there is the opportunity to leverage the lessons that have been learned from one country to the next. And finally, I'd just like to address two other things. The first is that the COVAX facility had set as the goal to provide enough doses to cover 20% of populations in 2021. And I do want to emphasize that it's not the intent of the COVAX facility to stop at 20%. Depending, of course, on the funding available and the interest of countries, especially self-financing countries, the facility is set up to deliver beyond 20%. So this is a facility that would not end in 2021 or end at 20%, but is designed to provide the provision of vaccine doses responsive to the epidemiology and responsive to the policies that would need to follow from that about what proportion of the population and how broad and widespread vaccination does need to be with as great speed as can possibly be achieved to get to protection of all people who need that protection to really end the pandemic. So I think it's critical on the country rollout that we're planning for and deploying with that in mind. Over. Thank you.
Thank you very much, Dr. Swaminathan, Dr. Samau, and Dr. O'Brien. Mr. Chair and members of the Executive Board, two last comments. The big message we heard yesterday was more communications. This was heard by WHO, by COVAX, by the facility, and especially by Gavi. Just this morning, we have published on the Gavi COVAX facility site the delivery plans in terms of the total volume of COVAX vaccines by month and by WHO region, as well as the split by AMC and self-financing participants. So that is published on the site as of this morning. We provided a view yesterday on the vaccine-specific products, and we will continue to do so and update this as we go forward. So the communications will be stepped up. This is very much the commitment of Gavi and very much possible now as we get a better sight on which product will actually work. I would remind you there are very important caveats to that timeline. We have 145 million doses contracted for release during the first quarter of this year. It depends on getting through regulatory support, continuing the financing to the Gavi facility, the COVAX facility, which I talked about, and to cooperations from the countries and entities that have large bilateral deals, because choices have to be made as to which contracts get served in which order. And the dose sharing that we mentioned yesterday. There is absolutely no question that COVAX can be successful, and it must be successful, as we've heard from the many, many who spoke on the need and the reliance on that mechanism. But so working depends on the countries that currently hold large contracts, the producers, and that is what the Director General emphasized yesterday. There's no question that we can achieve the DG's vision of all countries being vaccinated, their highest risk populations, by World Health Day, which is only a couple of months away. But to achieve that ambition will require a new level of cooperation and coordination as we go forward. Any suggestion that other mechanisms are needed to get vaccine out faster because of COVAX, and a suggestion it's not operational, has to be scrutinized. The facility, as we've described yesterday, is operational. It is ready to deliver vaccines. There are still specific things to be done at country level as that happens, but it can only happen with assured doses of vaccine as we move forward. Otherwise, Mr. Chair, you know, there's risk of there being a self-fulfilling prophecy where a failure to cooperate with the COVAX facility in terms of volumes, et cetera, could lead to delays. Not a failure of the COVAX facility, because it will deliver and deliver at scale. We want it to deliver as rapidly as possible, and that is within the power of the member states, without a doubt. So huge thank you again for all the advice, the guidance to us, and all the work and support so far to make the facility as successful as it has been. Key now is to get people vaccinated as rapidly as possible in the coming month.
Thank you, Bruce. Just again, thank you to the member states for your comments, your inputs, your constructive inputs that will lead us to make further efforts to improve our systems. Ever since WHO's full incident management system was activated on the 1st of January 2020, all of our staff at all levels have worked with huge energy, with courage, with conviction, and with the passion to serve you, our member states, and your communities. Together, we've tried to leverage every single capacity, partner, innovative idea, and we'll continue to do so in 2021. Thank you.
Thank you. And now back to His Excellency, Mr. Chair, Dr. Harsh Vardhan.
Thank you. As I see no more comments, I take it that the board is ready to note the report contained in document EB 148/16. I see no objections. The report is noted. This concludes the board's consideration of sub-item 14.1. We shall now consider sub-item 14.3, mental health preparedness and response for the COVID-19 pandemic. The report by the Director General is contained in document EB 148/20. The board is invited to take note of the report and provide further guidance. I understand that a draft decision on promoting mental health preparedness and response for public health emergencies is contained in document EB 148/conference/5. The financial and administrative implications of this draft decision, should it be adopted, are contained in document EB 148/conference/5 add 1. The floor is now open for discussion. I would like to request that the Secretariat moderate the discussion on the virtual platform. Secretariat, you can have the floor, please.
Thank you, Mr. Chair. May we kindly remind those member states wishing to make a statement to once again please raise their hand in the Zoom platform. I understand there will be a number of regional statements. That being said, I have the pleasure of giving the floor to the distinguished delegate from Austria. Thank you. You have the floor.
Thank you very much, Mr. President, Director General, Your Excellencies, ladies and gentlemen. The COVID-19 health crisis has exacerbated mental health conditions, and it has severely impacted the well-being of populations around the globe. The report published by the Secretariat underlines the concerns and negative trends we are observing in the current context. Measures to control COVID-19 have caused people with mental health conditions to be further isolated from their usual activities and contacts, leading to increased marginalization, distress, and have deepened concern over increasing feeling of fear, anxiety, and loneliness. Mr. Chairman, it is worrying to note that due to COVID-19, mental health and psychological support services have in many countries been severely disrupted. The EU is equally concerned that human rights violations against people with mental health conditions are numerous and widespread around the world.
Could the Secretariat ask the Speaker to slow down a little bit, please?
Have seen their mental health conditions severely impacted by the COVID-19 crisis. The pandemic has added another layer of complexity to already pre-existing humanitarian needs, especially with regard to increased violence and abuse driven by school dropout and lack of access to people in need, medication and food. Although all categories of people, age and gender are concerned, a worrying trend is being observed in children, adolescents, young adults, elderly, health and care personnel, marginalized and vulnerable people. Mr. Chairman, the EU and its member states are concerned by the emerging trends showing that social restrictions related to the pandemic are likely to cause increased depression, alcohol and other substance use, as well as online gaming and gambling in different segments of the population. The long-term impacts of these trends will be difficult to address, considering the immense challenges the pandemic is continuing to pose. Risk factors like unemployment and financial instability, missed education and lost prospects, social isolation, intimate partner and family violence, fear of life-threatening disease in self or loved ones, and sudden loss of loved ones are likely to add to increasing amounts of distress in our societies. We're encouraged to note that there is an increased awareness among policymakers that mental health crisis is of utmost concern and needs to be addressed as a matter of priority, taking into consideration the need to adopt a whole-of-society approach to promote, protect and care for mental health. The EU and its member states are committed to address immediate needs related to the availability of emergency mental health and psychological support and building mental health services and community support for a speedy recovery from the COVID-19 pandemic. At the same time, we recommend the Secretariat as well as Member States to use the current momentum to catalyse mental health reforms and to build back better, ensuring that mental health is part of universal health coverage in our societies. Likewise, we recommend the Secretariat to ensure that mental health and psychological support is considered as a cross-cutting component in emergency preparedness and response, including by increasing public knowledge on mental health and working against any forms of stigmatization. Thank you very much.
Thank you. And now to Gabon, to be followed by Bangladesh.
Well, Gabon has the honor of taking the floor to present the views of the 47 member states of the WHO African region on item 14.3, addressing mental health preparedness and response for the COVID-19 pandemic. We wish to congratulate the Director General on the excellent quality of the report provided to us, which highlights the situation of people with mental health conditions in the context of the response to COVID-19. In particular, the report underscores numerous human rights abuses, increased isolation and discrimination faced by people with mental health conditions as a result of the measures taken to contain the pandemic. In that regard, we recall that mental health is a public health problem that should be addressed as part of the pandemic response plan in accordance with Resolution 74-306/2020 of the UN General Assembly. We welcome the guidelines and recommendations adopted by the WHO Secretariat in collaboration with other agencies with a view to minimizing the consequences of the pandemic on mental health. Chairman, the goal of universal health coverage will remain out of reach if mental health and psychological support issues related to COVID-19 don't receive our full attention. The 47 member states of our region appreciate the activities undertaken by the Director General to promote mental health in emergencies. We call on the Secretariat to further support member states in the implementation of the disaster and emergency risk management strategy, in particular with regard to the establishment of a functioning multi-sectoral mental health and psychosocial support coordination platform. In addition, member states of the African region approved the updated Comprehensive Mental Health Action Plan 2013-2030 and request support for the regional office and member states in light of the challenges faced by the African region. That support would contribute to improving the delivery of mental health and psychological support services for people affected by COVID-19 and strengthening and scaling up mental health services, particularly at the community and primary healthcare levels. Lastly, the African region notes the report prepared by the Director General. Thank you.
Thank you. And now to Bangladesh, to be followed by Australia.
Thank you. Thank you, Mr. Chair. Bangladesh delivers the statement on behalf of the 11 WHO member states of the Southeast Asia region. What we have learned from the COVID-19 is the uncertainty. Despite being well planned, situation can change at any time. We must be prepared to respond to new challenges.
Distinguished delegate from Bangladesh, it seems that we're unable to hear you. If we could just do a quick sound check.
Can you hear me now? Can you hear me now?
We can. Please continue. Thank you.
Thank you. Thank you. Thank you, Mr. Chair. Bangladesh delivers this statement on behalf of the 11 WHO member states of Southeast Asia
Apologies,
region.
Bangladesh, we're unable to hear you once again.
Can you hear me now?
If we could try one more time, and failing that, we will come back to you shortly.
Can you hear me now?
Yes, let's try one more time. Thank you, sir.
Sorry for the inconveniences. Bangladesh delivers this statement on behalf of the 11 WHO member states of Southeast Asia region. What we have learned from the COVID-19 is the uncertainty. Despite being well planned, situation can change at any time. We must be prepared to respond to new challenges emerging under the rapidly changing situation. It is unfortunate that preparedness and responses to COVID-19 were mostly on physical health. Mental health was less prioritized area. While COVID-19 pandemic has major consequences on mental health and psychological well-being of all people, the impacts of the pandemic on mental health is not specifically recognized. For instance, the WHO Strategic Preparedness and Response Plan for COVID-19 has not specified any strategies to address mental health needs from COVID-19. Our region sees the need for member states to include mental health preparedness and response in public health emergency response, focusing on early mental health communication, mental health information system, and community surveillance, resilience. These include the whole range of comprehensive and integrated mental health services and psychological support, including promotion, prevention, early detection, treatment, and rehabilitation, and promoting mental health literacy and awareness in the context of COVID-19 pandemic. However, we should not pay attention to only short-term services as the long-term demand emerges long after the event. In addition, WHO should strengthen member states on implementation of the Global Mental Health Action Plan 2013-2030 in context of public health emergencies. Mr. Chair, Bangladesh would like to introduce draft decision on promoting mental health preparedness and response for public health emergencies. This draft decision is co-sponsored by Argentina, Bangladesh, Bhutan, Brazil, Canada, Guyana, Indonesia, Maldives, Myanmar, Norway, Peru, Qatar, Switzerland, Thailand, United States of America, and the member states of the European Union. In addition, we are glad to further inform EB members that Chile also co-sponsored this draft decision. We recognize Thailand's leadership in developing this document during the 3 rounds of informal consultation. We acknowledge hard work of the Secretariat in supporting the process of development of the draft. We also highly appreciate member states for their contribution by highlighting the importance of mental health aspect in the time of the pandemic. The draft decision will be the important tool toward strengthening capacity of the member states on mental health preparedness and response for the public health emergencies, especially for this COVID-19 pandemic, to better protect physical and mental health of all people. I thank you.
Thank you, Bangladesh. And now to Australia, to be followed by Tonga.
Australia thanks the Director-General for the Mental Health Preparedness and Response Report. Ensuring action on mental health is of critical importance. We support the recommended actions for minimising the mental health consequences of the COVID-19 pandemic and have ensured that in Australia, mental health is at the forefront of disaster preparedness, response and recovery planning. In response to COVID-19, we have applied a whole-of-society approach to mental health. We have focused on supporting the economic needs of Australians, along with improving access to mental health services through measures such as telehealth and providing targeted mental health and psychosocial supports to those who are most vulnerable. We also acknowledge the importance of accessible and affordable quality community-based mental health services to support recovery from COVID-19. Australia acknowledges that there is a high prevalence of comorbidity between substance abuse and mental health illnesses, and that social restrictions imposed by the pandemic has exacerbated these problems for many people. For this reason, we support the inclusion of recommendations to adapt service delivery models to treat substance use disorders in response to the COVID-19 pandemic. Additionally, we support the planned activities by the Secretariat, particularly on the collection, analysis, and reporting of data on substance abuse. The mental health and wellbeing of Australians remains one of the highest priorities for the Australian Government, We're committed to implementing broader mental health system reforms that address lessons learned during the COVID-19 pandemic. Australia acknowledges the impact of the pandemic on the mental health and wellbeing of WHO staff. We note the actions taken by the organisation to support its staff during these challenging circumstances, and we encourage this to continue. Additionally, we would like to echo the comments made by the Chair and the Director General at the start of the EB and thank all essential health workers, scientists and researchers around the world for their continued dedication. The success of our response is built on their hard work. Finally, Australia thanks Thailand for its leadership on the decision under this item and is pleased to announce we will be a co-sponsor. Thank you.
Thank you. And now to Tonga, to be followed by India.
Honourable Chair, on behalf of His Majesty's Government, the Kingdom of Tonga and the Pacific, we welcome this report on mental health preparedness and response to COVID-19 pandemic. While most of the Pacific countries remain free of COVID-19 or without community transmission, the pandemic has affected our people in many ways. Some people have lost their income as tourism is the main source of income for many of the Pacific Island countries. Some lost their families and friends living abroad to COVID-19 as many Pacific Islander migrate across the globe. Some were separated due to border closure in many countries. Some countries have imposed lockdown which put people in isolation or in crowded and unsafe environment. Domestic violence appeared to increase during lockdown. Also, the stress and pressure among the frontline workers are tremendous. They are every day at risk of exposure to the virus, and on top of that, sometimes discriminated from the community as seen as high-risk group. All these stress and distress will lead to worsening of mental health. Anxiety and depression can be felt in many people, especially it has been prolonged for more than a year. In the Pacific countries, we were supported in mental health and response for COVID-19 pandemic through the Mental Health Psychosocial Cell under the Joint Incident Management Team. They have adapted various documents developed by WHO and other agencies to the Pacific situation, developed online training materials, developed tip sheets for various settings such as quarantine facilities, and conducted communication campaigns and provided direct support to many of the member states in the region. In Tonga, we have trained nurses on the basic psychological skills to cater for increased psychological needs. To raise the profile of mental health, we have endorsed in Tonga the first ever national mental health policy and established a new division for mental health promotion and prevention of mental illness within the ministry. This is a mega milestone achievement and recognition of mental health in the kingdom. Finally, we appreciate the report and commit to strengthen mental health system to respond to COVID-19 and to enhance Tonga and Pacific populations' mental health well-being. Thank you, Honourable Chair.
Thank you very much, Tonga. And now to India, to be followed by Colombia.
Preemptively acknowledging the impact that the COVID-19 pandemic may have had on the mental health of people, the Government of India has taken several initiatives to provide mental health and psychosocial support during the pandemic. These include setting up of a 24/7 helpline to provide psychosocial support by mental health professionals to different target groups,
such as children, adults, elderly, women, and healthcare workers. Online capacity building of health workers by providing psychosocial support and training through the iGOT platform, and issuing detailed guidelines by India's premier National Institute of Mental Health and Neurosciences, Bangalore. To promote an environment of support and care, risk communication was taken up through various media platforms in the form of creatives and audiovisual materials, and guidelines were issued on management of mental health issues catering to different segments of society. Chair, mental health has been an important issue in the Indian healthcare landscape, and we have been implementing the National Mental Health Program since 1982 to address the huge burden of mental disorders and acute shortage of qualified professionals in the field of mental health. The objective of the program has been to provide basic mental health services to the community and integrate them with the general healthcare services. Chair, India launched the National Mental Health Policy in 2014 with a vision to promote mental health, enable recovery from mental illness, promote destigmatization and desegregation, and ensure socio-economic inclusion of persons affected by mental illness by providing accessible, affordable, and quality health and social care to all persons throughout their lifespan within a rights-based framework. India has also enacted the Mental Health Care Act 2017 to provide mental health care and services. The above initiatives indicate India's commitment of making efforts to address the growing need for mental health and psychosocial support, more so after the COVID-19 pandemic. India concurs with Bangladesh's intervention and supports the draft resolution by WHO on promoting mental health preparedness and response for public health emergencies. Thank you.
And now to Colombia, to be followed by Israel.
Thank you, Chair. Can you hear me?
Yes, please proceed.
Thank you. Agradecemos el informe presentado por el director general sobre la preparación y respuesta en materia de salud mental para la pandemia de COVID-19. Consideramos que la salud mental es uno de los temas que toman mayor relevancia en el marco de la actual pandemia que afrontamos los países producto del SARS-CoV-2. Queremos resaltar que el informe es un documento de alta prioridad para nuestro país, teniendo en cuenta que plantea el marco general de las acciones para el cuidado de salud mental en el contexto de pandemia y pospandemia. En este sentido, es imperativo que la orientación estratégica en este particular se haga operativa mediante la actualización del Plan de Acción Integral sobre Salud Mental 2013-2020, como se propone en el informe, para que facilite la adopción práctica de las recomendaciones derivadas de la pandemia. Colombia incluye dentro de las 10 prioridades en salud pública a la salud mental y la prevención y atención al consumo de sustancias psicoactivas. Asimismo, son prioridades del Plan Nacional de Desarrollo 2019-2022 y dentro de los objetivos de desarrollo se ha priorizado reducir la tasa de intento de suicidio en un 5% anual, así como aumentar el número de atenciones para personas en riesgo o consumo problemático de sustancias psicoactivas. En nuestro país, tras un largo proceso de concertación, se publicó la Política de Salud Mental, que convoca la acción sectorial e intersectorial coordinada en el corto y mediano plazo, previendo atender las afectaciones en salud mental que persistan tras superar la emergencia sanitaria por la pandemia de COVID-19. Esta política busca resaltar propuestas de participación social y propone acciones concretas de 14 entidades nacionales con un alto presupuesto de inversión. También tiene como objetivo promover la salud mental de la población colombiana a través del fortalecimiento de entornos sociales, el desarrollo de capacidades individuales y colectivas, el incremento de la coordinación intersectorial y el mejoramiento de la atención en salud mental, con el fin de reducir la incidencia de problemas o trastornos mentales, el consumo de sustancias psicoactivas y las violencias. De igual forma, se han promovido respuestas estratégicas de primera línea ante el brote de COVID-19 en el marco de las orientaciones de política pública, lineamientos operativos y financiamiento. Se destacan las estrategias de comunicaciones intersectoriales diferenciadas por tipo de públicos, el apoyo al talento humano en salud, la promoción y fortalecimiento de la telesalud, la activación de servicios de urgencias y emergencias en salud mental, entre otros. Por otra parte, vale la pena señalar que la gestión durante la pandemia se ha caracterizado por la generación de lineamientos y recomendaciones técnicas a los actores del sector salud, en particular del Sistema General de Seguridad Social en Salud, el desarrollo nacional y territorial de capacidades en salud mental y consumo de sustancias psicoactivas y la gestión intersectorial en el desarrollo de la estrategia para cuidado en salud mental y promoción de la convivencia. Finalmente, queremos realizar un llamado a la organización para que continúe apoyando a los países con recursos técnicos en el fortalecimiento de la implementación de programas y proyectos en materia de salud mental que contribuyan a robustecer la respuesta de los países ante el incremento de casos producto de la actual emergencia sanitaria.
Thank you, Chair.
Now to Israel, to be followed by the United States of America.
Thank you. Thank you, Moderator, Director General, Member State Excellency. For too long, mental health was a neglected issue, and the State of Israel supports the WHO stand to ensuring that mental health is placed in the forefront of our discussions, especially during COVID-19 pandemic, which has had such a negative impact on mental health worldwide. One of the most significant challenges of this pandemic has been the strain on people's mental health due to fatigue, uncertainty, isolation, and several other reasons. It is critical to recognize that the pandemic has taken its toll on all of us, even those who may have been considered mentally healthy before the pandemic. We have all felt the effect of COVID-19, and we must come together to support one another to ensure that we do everything we can for the mental health of people worldwide during this time. This is one of the many reasons the WHO work during COVID-19 has been critical for health systems everywhere. On the national, regional, and global level, we must not forget our duty to ensure that mental health and well-being is properly addressed in our pandemic response. And the WHO has ensured that there is sufficient evidence to exactly how to do this. We support the WHO position paper, recommended actions, especially to apply a whole of the society approach to promote, protect, and care for mental health. We in Israel have been especially grateful to social workers, psychologists, nurses, doctors, who have been integrated in generating mental health care where needed. But also to social civil societies and volunteers who have offered themselves to this cause. In Israel, our Protect Mother and Father program, which was for the elderly population, has been calculated success both in protecting the physical and mental health of the elderly population in Israel, who have found themselves especially strained and isolated during this pandemic. We also support WHO recommendation to ensure widespread availability of emergency mental health and psychological support. In Israel, we have recognized the importance of these services and offer them in many languages for our population to maximize patients' comfort and to ensure the best possible mental health care. Lastly, as we have stated, one of the most important lessons to be learned from the COVID-19 pandemic is how we can strengthen
the services for the future. For that reason, we support WHO recommendation to build and strengthen the mental health services in the future, especially to ensure that mental health services are a part of the universal health coverage package for equal and high quality access for the whole of the population. Thank you for ensuring this critical topic in the highlights. Thank you very much.
And now to the United States of America, to be followed by Indonesia.
Thank you, Chair. The United States thanks WHO for the report highlighting the critical and underrepresented issue of mental health and public health emergencies. We recognize the short and long-term impacts of COVID-19 pandemic has had and will continue to have on mental and psychosocial health. We also appreciate Thailand's leadership of the accompanying decision on promoting mental health preparedness and response for public health emergencies, which we are pleased to support and co-sponsor. The United States supports the recommended actions for WHO and member states referenced in the report and in the decision, including recommendations to apply a whole of society approach to promote, protect, and care for mental health, ensure widespread availability of emergency mental health and psychosocial support, and support recovery from COVID-19 by building and integrating mental health services for the future. We encourage WHO and all member states to pursue these recommendations to the highest level in response to the COVID-19 pandemic and in preparation for future pandemics and other public health emergencies. As with other aspects of emergency response, we are more effective when we work together and include all experiences and lessons learned to defeat the pandemic and rebuild our economies. The United States highlights in this regard the important contributions of Taiwan could make to these discussions, as well as other aspects of COVID-19 response, if they were allowed to participate fully as an observer to WHO's technical work. As we act on these recommendations, it is crucial to emphasize the continuation of information gathering on COVID-19's effect on mental health and psychosocial support infrastructure, continuity of care, ramifications on neurological health associated with severe COVID-19 illness, and the support of primary and community mental health services. We need to pay particular attention to vulnerable populations, including children and adolescents, senior citizens, women who are often caregivers, and persons with disabilities. Thank you, Chair.
Thank you. And now to Indonesia, to be followed by China.
Thank you, Chair. At the outset, we would like to express our appreciation to the Secretary for report. Thank you. Indonesia aligned itself with the statement made by Bangladesh on behalf of the Southeast Asia regional countries. And we would like to reiterate our deep concern that the COVID-19 pandemic has impacted negatively to the mental health of the population, in which it has not been addressed enough. In this regard, we support the need to include mental health preparedness and response in public health emergencies response. And there have been many cases in which health worker in mental health has been aggravated due to the high COVID-19 cases, death rate, workload, as well as the lack of personal protective equipment. This brings new challenge in protecting health workers and first responders during the pandemic, in which some of them have lost their life. We condemn any attack to health workers, especially during their noble work at the community level. On the other hand, mental health problem has also been exacerbated in the wider population due to the implementation of physical distancing strategies. It is also impacted by quarantine procedure for those who have been exposed to or infected with COVID-19 as a means to reduce the transmission of the viruses. The social isolation, along with the loss of income, anxiety, and bereavement, also triggered psychological problem among community. Chair, while mental health cases rise due to the pandemic, mental health services have been significantly disrupted in the red zones in a few big cities in our countries. In our case, psychiatric hospitals are among the most susceptible places to the spread of the COVID-19. The enclosed living quarters and contacts within mental health unit increase the possibility for transmission. To address this, Indonesia has developed a standard operational procedures as well as protocols on mental health services and psychosocial support system during the COVID-19 pandemic, particularly for healthcare and social workers. To facilitate wider access to the community, we have also developed a mobile application that provides mental health services, including information on nearby mental health services and questionnaires for assessing mental health condition. This optimization of telemedicine utilization has been advantageous to increase access to mental health care services and improve patient engagement. And Chair, as a final point, my delegation support the draft decision on mental health for public health emergency for the COVID-19 pandemic as proposed by the government of Thailand. Solidarity at the global level is a must in promoting mental health preparedness and responding to the public health emergency. Thank you, Chair.
Now to China, to be followed by Sudan.
Thank you, Madam Chair. COVID-19 not only poses a serious threat to public life and health, but also has a strong impact on people's psychology. China supports DG's report on mental health in the context of COVID-19. In particular, at the end of April last year, the DG proposed that various countries should take mental health as an indispensable and important factor in responding to public health emergencies. This is significantly important during and in the post-pandemic efforts. Our government attached great importance to the psychological support in emergencies. Since the outbreak, President Xi Jinping has instructed on many occasions to strengthen psychological counseling and interventions, called for strengthening such service to patients, their families, and families of the deceased, called for attention to be accorded to people's psychological during quarantine. The National Health Commission has taken the lead in formulating guiding principles for interventions in emergencies, psychological crises, successively issued psychological counseling, organized online service through hotlines and online platforms, selected health professionals to carry out face-to-face interventions and trainings at the front line, and organized experts to write popular books and animation videos on psychological counseling for wide dissemination to the whole community. At the same time, we also pay attention to the prevention of mental illness in emergencies. In order to resolve their treatment through remote video follow-ups and timely delivery of drugs to the doorstep, we ensure patients uninterrupted treatment when in self-isolation. For poor patients, more free treatment and assistance has been provided, including those who have mental illness and confirmed COVID cases. With the support and guidance of the WHO, Chinese experts have also conducted many online exchanges with other countries to share our experience and practices during the pandemic. As the next step, China will continue with the prevention and control of the pandemic, strengthen the psychological assessment of key populations, implement mental health measures, and help the public mitigate their negative emotions and trauma caused by the pandemic. Meanwhile, we hope that the WHO can focus on two issues. One is the psychological changes of adolescents during the pandemic, as some data show that these people suffer more psychological shocks during the pandemic. Second is the comprehensive guarantee of psychological support, which does not only include the financial investment in remote intervention and crisis hotlines, but also the issue on how to ensure adequate human resource with professional background and the systematic infrastructure capacity building. Thank you, Madam.
Now to Sudan, to be followed by Kenya.
Thank you. Esteemed Chair, members of the EB, ladies and gentlemen, I'm delighted to be reading the statement on behalf of the Amber region. In face of the unprecedented spread of the COVID-19, we express our deep concern regarding the impact of the pandemic that has had and continues to have on mental health and well-being of the whole societies. This has been exacerbated by the consequences of the COVID-19 related precautionary measures taken at global level to curb the spread of the disease, including physical isolation, poverty, and economic anxiety. We make a strong and clear commitment to the importance of putting mental health front and center of the preparedness, response, and recovery plans for the COVID-19 pandemic to promote mental health and scale up mental health and psychological support services to support people to cope with COVID-19. At this decisive juncture, now more than ever, the global community must remain focused on accelerating the implementation of 2030 sustainable development and humanitarian agendas. Addressing the issue of mental health is critical to achieving these agendas. To that end, our effort must be redirected to the immediate challenge of strengthening our collective action to readdress the chronic underinvestment in mental health without delay, making sure that mental, neurological, and substance use disorders are included in the UHC benefit package and building human resources capacity to deliver mental health and social care to prevent a massive increase in mental health conditions and to mitigate long-term social and economic costs to society. We encourage WHO to take the lead in developing a strategy to ensure that governments have the support to mitigate the impact of COVID-19 on mental health. I thank you, Chair.
Thank you. And now to Kenya, to be followed by Argentina. Sorry, distinguished delegate from Kenya, it seems we're having some difficulty hearing you. Let us just try once more with the volume.
Kenya aligns this statement with that delivered by Gabon on behalf of the African member states. Like most countries...
Apologies, distinguished delegate from Kenya, the sound is very faint from this end. And our interpretation services are unable to interpret. May we try once more, and failing that, suggest that we move on and come back to you. Thank you.
Thank you, Chairperson. Kenya aligns this statement with that delivered by Gabon on behalf of the African member states.
I'm terribly sorry, Kenya. It seems that we are unable to audibly hear you. If I may suggest that we move on to Argentina, and our IT will work with yours to try and resolve the issue. Thank you for your understanding. And now, Argentina, you have the floor.
Gracias, señora moderadora y señor presidente.
Thank you, moderator, and thank you, Chairman. Argentina has taken careful note of the document. We are aware that we had a problem with providing mental health care before the pandemic, and now we have further problems related to alcohol abuse and other psychoactive substances as a result of it. One of the major challenges we faced during the COVID-19 pandemic has been to avoid not being able to provide mental health care and to ensure that those were provided without a break to the population, particularly the most vulnerable groups. Through our National Health Ministry, we have tried to guarantee access to and continuity of care remotely. We've also tried to continue to provide the necessary medicines, again by digital means, and we have tried to provide mental health care to workers in the frontline in the health system. They are obviously suffering from considerable overwork and very high levels of stress. We've also developed and published recommendations to prevent the virus getting into mental health institutions, psychiatric hospitals, for example, and to guarantee access to care for people in those institutions if that were to happen. The social fabric has been considerably damaged by this pandemic in our region, and because of that, we have been trying to provide proper, good quality care despite the pandemic. We intend to continue to promote our integrated healthcare networks, which will take into account local circumstances, by providing mental health care for boys and girls, adolescents, older people, people from indigenous communities, and people with mental illnesses, among other priority groups. Last but not least, we thank the delegation of Thailand for submitting the draft resolution promoting preparedness for and response in terms of mental health care in public health emergencies. We co-sponsor it and believe it very valuable. We also think it's essential to support recovery after the COVID-19 pandemic is over, particularly by promoting mental health and psychosocial well-being. This means having strong mental health care services and strengthening our preparedness, our response capacity, and our resilience so that we can deal better with future health emergencies. We also need to strengthen WHO's capacity to do the work it does on mental health globally, regionally, and locally. Thank you.
Thank you, Argentina. And now to Austria before we try and cross back to Kenya. Austria, you have the floor.
Thank you, Honorable Chair, dear members of delegates for the Executive Board. Austria aligns itself with a statement on behalf of the European Union and its member states. Austria thanks also the Director General for his report on this important topic. In view of current priorities, Austria attaches great importance to WHO efforts in the field of mental health during the COVID-19 pandemic. The pandemic and its consequences causes a variety of psychological stress. The peak of psychological stress may be reached only after the causes of the original crisis have subsided. Psychological stability of the population is an important prerequisite for people's participation in crisis management and subsequent societal regeneration. Therefore, mental health monitoring and measures aimed at maintaining or improving mental health is an indispensable part of crisis plans and strategies at the level also of our national crisis task force in our country. In our current COVID crisis plan, Austria has a chapter on mental health, focusing on social support to reduce existential fears, on easy access to non-specialized physiological support, and on maintaining access to services for acute mental needs. From a mental health perspective, public information and communication strategies too are important in times of crisis. Messages conveyed to people should be comprehensible to different target groups, support them in their ability to act accordingly, and give them meaning and perspective. Therefore, Austria supports the draft resolution on mental health during the COVID-19 pandemic, and I yield back to you, Chair. Thank you.
Thank you very much. And let us once again try and connect with Kenya. Kenya, you have the floor.
Thank you, Chairperson, and apologies for the terrible inconvenience and the delays caused by what happened. I hope I'm now audible.
Certainly. Thank you very much.
Thank you. Kenya aligns this statement with that delivered by Gabon on behalf of the African member states. Like most countries, Kenya adopted a whole of society approach to promote, protect, and care for mental health as an essential component of the national COVID-19 response through various mental health and psychosocial support activities. Under this initiative, social welfare assessment and reintegration of people in quarantine and isolation back to their communities was also supported. Furthermore, Kenya also developed mental health and psychosocial support guidelines for public health emergencies. In this regard, psychological first aid training was prioritized for COVID-19 response teams and front health workers, as well as community health volunteers and assistants to strengthen mental health psychosocial support response at the community level. Chairperson, the mental duress and anguish caused by the pandemic has severely affected lives and livelihoods and had catastrophic impacts on our citizens. This has brought to the fore the need for more investment into management of mental health. Kenya therefore calls for WHO, member states, and all international actors to work together to highlight the state of mental health support in health management. Kenya commits to continue its daily communication updates on COVID-19, strengthening of community-based psychosocial support for the COVID-19 affected persons, and to increase access to quality, affordable care for mental health conditions within health and social services as envisioned under the government's Universal Health Coverage Agenda. In conclusion, Chairperson, Kenya welcomes the proposed strategic objectives and activities to reduce suffering, promote human rights, and improve the mental health of all people affected. Kenya stands ready to support the process and requests the Director General to ensure that the mental health needs and support is adequately captured in the next budget. Finally, we thank Thailand for their initiative in proposing a resolution on mental health and COVID-19 and request to be listed as co-sponsor of this resolution. I thank you.
Thank you very much, Kenya. And we should now move to statements by those member states not represented on the board. I should wish to invite the distinguished delegate from Thailand to be followed by Japan. Thank you. Thailand, you have the floor. Thailand, just wishing to confirm you're still in a position to deliver your statement.
Thank you, Chair. Thailand aligns itself with the regional statement made by Bangladesh and appreciate the Secretariat for the comprehensive report. We emphasize two neglected points on mental health. Firstly, the COVID-19 pandemic affected people physically and mentally. We usually focus on short-term mental health services. However, mental effects from crisis last longer than the event. For example, depression and suicide. So we need to pay more attention to the long-term demand that emerged long after the pandemic. Secondly, mental health service provision should not be only hospital-based services, but it should be also extended to community-based services to ensure comprehensive and continuity of care. Moreover, we should promote mental health literacy and awareness to the society to enhance resilience in all people and reduce stigmatization. Chair. Lastly, Thailand, as the chairperson of 3 rounds informal consultation, would like to thank member states and the Secretariat at WHO headquarters and CLO for their genuine support and significant contribution in developing and shaping this decision. It will lead to a broader whole of society approach of mental health services and psychosocial support during public health emergencies. Thank you, Chair.
Thank you. And now to Japan, to be followed by Norway. It would seem we're unable to connect with
Can you hear me?
Oh, yes, please proceed. Thank you.
Thank you, Chair. We appreciate the report from the WHO Secretariat Japan emphasizes that information on infectious status should not cause stigmatization of a specific individual or community. However, in reality, we see some cases in which human rights have been infringed, including those who are infected with COVID-19 and their families, or people who work at hospitals or provide health-related services. Therefore, we are firmly determined to take appropriate measures to address and prevent these situations. For example, during COVID-19 pandemic, we support vulnerable people and take the following measures. First, preventing mental health effects due to a long period of self-isolation, domestic violence, and child abuse. Second, paying attention to balance between information disclosure and human rights protection. Third, preventing bankruptcy, unemployment, and suicide. Fourth, supporting life of older persons living alone or single-parent families who tend to be socially isolated. Fifth, maintaining health and long-term care of the older persons. Moreover, we appreciate the important role of WHO Western Pacific Regional Office for its work to provide the guidance of mental health and the psychosocial support aspects of the COVID-19 response, and we fully support this work. Since COVID-19 pandemic will continue to affect our society, we welcome the Secretariat's further technical support to address mental health, and we look forward to receiving a progress report in the future. Thank you.
Thank you, Japan. Just before we do take the statement from Norway, I understand we have another EB member wishing to take the floor. Singapore, you have the floor. Thank you.
Thank you, Chair. Mental health is essential to our overall well-being. Given that mental health is one of the most neglected areas of health, it's important to highlight that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease. With COVID-19, more people around the world are facing increased stresses, pressures, and disruptions to their lives and livelihoods. In Singapore, 1 in 7 persons will suffer from a mental health condition at some point in their lives. Thus, ensuring access to quality mental health care for every citizen is a major priority. We have strived to raise mental health literacy, promote early intervention, and improve mental health services. On the pandemic, we recognize that it is likely to have a long-tail effect on mental health as stress levels rise with the uncertainty and the global economic downturn. For this particularly demanding period, the National Care Hotline to provide psychological first and emotional support to the public. We've also convened a COVID-19 mental wellness task force to provide a coordinated national response to the mental health needs of Singaporeans arising from the pandemic. This interagency task force will review the psychosocial impact of the pandemic on the population and take stock of government initiatives introduced. It will also identify gaps that will need to be addressed to better meet the mental health needs of our population. Like many organizations working remotely over an extended period of time, WHO staff are showing signs of mental fatigue affecting their overall mental health negatively. It's even more important that all of us work together and care for one another during these difficult times. We applaud and appreciate the hard work and dedication shown by WHO staffs. Your efforts are recognized and you are not alone. Thank you.
Thank you very much, Singapore. Thank you. And now to Norway, to be followed by Belgium.
Thank you, Chair. We commend the Secretariat for the excellent report on mental health preparedness and response for the COVID-19 pandemic. Mental health is one of the most neglected areas of health. This underlines the need to rethink how we can ensure services for the most vulnerable groups in a crisis. In Norway's strategy on NCDs in our development policy, we put a special emphasis on mental health, ensuring that mental health services are included in primary health care is not less important now during the pandemic. An investment in continuity in service provision is a cost-effective way to prevent an increased need for services in the long term after the pandemic. In a health crisis, besides the immediate measures to prioritize the most vulnerable, the focus must be future-oriented to proactively prevent problems in the younger generations. Therefore, children and youth and their families should receive necessary follow-ups in an intersectorial context. In other areas, our work on mental health should be integrated and is an important part of the implementation of the Global Action Plan on NCDs. Finally, Chair, we thank Thailand for putting forward the decision on promoting mental health preparedness and response for public health emergencies. We believe that it sets a strong direction for the need to increase our joint efforts to promote mental health and psychosocial well-being, and we are proud to co-sponsor it. Thank you.
Thank you, Norway. And now to Belgium, to be followed by Portugal.
Thank you, Chairman. Thank you, Moderator, and thank you for giving us the floor. Belgium supports the position of the European Union as presented by Austria earlier. We would like to thank the Director General for his report and for the efforts WHO has been making to promote mental health during the pandemic. Our country has, for quite some time, been focusing attention on this unfortunately very much neglected field of mental health, mainly through the action taken by Her Majesty Queen Mathilde. The COVID-19 pandemic and its consequences have had a considerable direct and indirect impact on the mental health of our peoples. It's also increased risk factors such as isolation, violence, school dropout, and so forth. Once again, the most vulnerable people in society are the most affected. For example, people who are in medical institutions, health professionals, and those in unstable employment are more exposed than others. We are particularly concerned by the disproportionate way in which women have been affected. There has been an increase in domestic violence cases and in cases of sexual violence since we started to impose lockdowns, for example. Of course, it's essential to ensure access to and support for mental health services, but we also need to act preventively. That means constantly bearing in mind the consequences that health-related measures have on mental health so that we can take appropriate measures to tackle them. Last but not least, we must structure the emergency innovations that have been brought in the mental health sector so that we can guarantee access to care by methods such as phone helplines, remote consultations, etc. And we must make sure that we maintain this multidisciplinary and outside institution approach to mental health. I would also like to endorse what Singapore just said and express my warmest thanks to WHO staff for their mental resilience. Thank you.
Thank you very much, Belgium. And now to Portugal.
Thank you. Mr. Chair, Director General, Excellencies, Portugal aligns itself with the statement previously made on behalf of the EU and considers this topic an absolute priority for action. Over the past months, we worriedly watched as the pandemic triggered a global mental health and human rights emergency. The harmful impacts of the COVID-19 pandemic is measured by more than mortality and morbidity caused by the disease itself, but also by its indirect effects, namely on people's mental health. Today we face significant increase in distress episodes, anxiety, and other mental health issues, and exacerbation of pre-existing conditions, fueled by stress, fear, worry for the virus, loss of living opportunities, and uncertainty about the future, as well as indirect consequences of the pandemic and the public health measures meant to counter it. Implementation of movement restrictions, for example, has changed the way people socially interact, leading in specific occasions to a feeling of despair, helplessness, and loneliness. Mr. Chair, Mental health in the context of preparedness and response should focus on prevention strategies, psychosocial supports, and community-based, people-centered services, guaranteeing a full access to a range of support amenities based on respect for human rights and the right to live independently. We urge WHO to redouble its efforts on the promotion of human rights in the context of mental health, including through its Quality Rights Initiative, which we praise. There is no health without mental health, so a paradigm shift is still needed towards comprehensive and holistic actions in order to mitigate the negative impacts exacerbated by the pandemic. Thank you.
Thank you very much, Portugal. I understand that we have come to the end of this morning's session. We do have left 8 speakers and 4 non-state actors. However, I would like to hand back to Mr. Chair.
Excellencies, distinguished delegates, it is now 1 p.m. Central European Time and time for taking the scheduled 1-hour break. We shall reconvene at 2 p.m. Central European Time to resume our discussions. Agenda item 14.3 is suspended for the time being, and we will take up agenda item 14.2 when we come back at 2 p.m. Thank you. Welcome back after the break. We shall now consider sub-item 14.2, WHO's work in health emergencies. There are 4 relevant documents under this item. Document EB 148/17 provides information on all WHO Grade 3 emergencies, United Nations Inter-Agency Standing Committee Level 3 emergencies, and public health emergencies of international concern that required a response by WHO between 1st January and 31st August 2020. Document EB 148/18 on strengthening WHO's global emergency preparedness and response. Document EB 148/19 provides the interim progress report of the Review Committee on the functioning of the International Health Regulations 2005 during the COVID-19 response, and document EB 148/information/4 draws the attention of the board to a report on progress by the independent panel for pandemic preparedness and response. I understand that a draft decision on strengthening WHO's global health emergency preparedness and response is contained in document EB 148/conference/4. The financial and administrative implications of this draft decision, should it be adopted, are contained in document EB 148/conf/4 add 1. Before I open the floor for discussion, I shall give the floor to the Secretariat to introduce the item and for the updates from the Independent Panel for Pandemic Preparedness and Response, the Independent Oversight and Advisory Committee for the WHO Health Emergencies Program, the Review Committee on the Functioning of the International Health Regulations 2005, and the Global Preparedness Monitoring Board. Secretariat, you can have the floor now.
Thank you, Your Excellency. In my report to the Executive Board yesterday, I said that we all have lessons to learn from the pandemic, every member state and the Secretariat. I said that we're committed to accountability and that we will continue to learn, to change, and to listen. And I described some of the lessons the pandemic has already taught us. Several review processes are underway. examining different aspects of the response. And today, you will be hearing from the chairs of the Independent Panel for Pandemic Preparedness and Response, the IHR Review Committee, the Independent Oversight and Advisory Committee, and the Global Preparedness Monitoring Board. As you know, in accordance with World Health Assembly Resolution 73.1, I established the Independent Panel for Pandemic Preparedness and Response to review experience gained and lessons learned from the pandemic and to make recommendations to improve national and global preparedness and response. WHO is grateful for the panel's work to date, and we look forward to its final report and recommendations. Today, I'm pleased to welcome the panel co-chairs, the Right Honourable Helen Clark, former Prime Minister of New Zealand, and Her Excellency Ellen Johnson Sirleaf, former President of Liberia, and to brief you on the panel's interim report. Former Prime Minister Clark, former President Sirleaf, thank you for your commitment and for joining us today. You have the floor. President Sirleaf or Prime Minister, yeah.
Yeah, Helen is on. Oh, she's mute.
Can you unmute, please? I think it's from our side, probably.
Yeah, they control the. Madame is unmuted. But Madame doesn't go first.
I'll just put my up just in case.
Have you? Huh? Who speaks first? President, okay. So Prime Minister Clark is speaking first. So can
Thank you. Thank you. Thank you, Dr. Tedros. Minister Vardhan, Chair of the Executive Board, all members of the board and guests of the Executive Board, thank you for enabling Co-Chair President Sirleaf and me to brief you today on some of the emerging findings and messages from the independent panel's second progress report. Obviously, all of us gathered here are so acutely aware that the pandemic we are experiencing is unprecedented in our lifetimes, and that it continues to rage, and that COVID-19 itself continues to evolve. 2 million people have died. There have been over 95 million recorded infections. These are sad milestones. The impact on human lives, the great strain placed on health systems, and the scale of the social and economic devastation brought about by the pandemic make it clear to our panel that the world needs to do two things: act more decisively now to stem the pandemic, and fundamentally to reset preparedness and response systems to help ensure that this can't happen again. And those 2 points are at the core of the panel's progress report, which we're presenting to you today. These are, of course, not abstract policy issues. In a recent meeting, which our panel hosted with the global nursing community, we heard directly from nurses about the crisis they see in healthcare facilities. So many nurses, they report, are burnt out. They report that many colleagues want to leave the profession when the main impact of the pandemic is over. Yet already the world was estimated to require the creation of 6 million more nursing jobs by 2030, and Exodus now exacerbated those pressures. And that's just one of so many spillover impacts of the pandemic. Since we were appointed by the Director General as co-chairs of the panel in July last year, we've heard from a wide range of stakeholders, and the feedback we've received has included very helpful and forward-looking contributions made directly by member states. We have made progress on synthesising all the contributions received, And we are building the necessary evidence base required for the comprehensive, impartial and independent review of the international health response to COVID-19 with which we were tasked. While our evidence gathering continues, the progress report before you now does have an unequivocal message that course correction and handling the pandemic is needed now. And our panel does strongly recommend that all countries immediately and consistently adopt and implement those public health measures which will reduce the spread and the impact of COVID-19. Simply put, we must do all we can to stop the pandemic now, and there are the means available to do so. The tools which can reduce the numbers of cases and deaths must be used. Those tools are familiar to this audience. The need to test and detect cases as early as possible, to do the contact tracing, to do the isolation of those infected, to reduce the spread through physical distancing and mask wearing. These measures are as relevant now as they were at the outset of the outbreak. The countries which make consistent and sustained efforts to implement such basic measures will benefit from reduced transmission, illness and deaths. Our panel's report does identify a series of critical early failings in the global and national responses to COVID-19. There had been a failure to prepare adequately for a pandemic threat, despite years of warnings that better preparation was necessary. Taken as a whole, the preparedness methods which were being used did not appear to predict how well individual countries would be able to control COVID-19. Perhaps because they couldn't capture what seems to be a critical dimension in pandemic control. That is the mix of government effectiveness, concerted leadership, capacity to work with communities, and being able to be guided by science. The report does consider whether the international system acted fast enough to detect and alert the world to this novel infectious pathogen with pandemic potential. And once the alert was issued in the form of the public health emergency of international concern, whether countries were fast enough to respond. Let us be clear, there can be no doubt that many people were working very hard at the time the new virus was emerging in order to understand what was happening and to mitigate the threat. What we say here today and in our report is in no way a reflection on the commitment of dedicated professionals. It's all oriented towards learning for the future. With the benefit of hindsight, detection and alert may have been speedy by the standards of earlier novel pathogens, but viruses move in minutes and hours rather than in days and weeks, especially in the highly mobile and interconnected world of today. Then, when almost 4 weeks after the new virus was identified, the WHO declared the highest possible alert agreed in the international system, that public health emergency of international concern, too many countries failed to act quickly and decisively enough to apply necessary and recommended public health measures. The panel believes that the international system for alert and response has the trappings of an analog system in a digital age. Modern information systems pick up signals of potential disease by sifting through hundreds of thousands of data points daily, outpacing formal country reporting and outpacing the procedures and protocols of the international health regulations, including that all-important declaration of the public health emergency of international concern. So the panel is looking at what might be needed for mechanisms to work at the speed necessary and to be able to integrate signals into real-time, globally available data gathering and decision-making tools. Let me now hand over to Co-Chair President Sirleaf to share some more of the messaging and finding from this interim report. Thank you.
Thank you, Prime Minister Clark. Greetings to all of you. I want to underline two additional concerns from the panel's report. First, the pandemic has laid bare inequalities both within and between nations, and the response has deepened those inequalities. As with so many pandemics in history, poorer nations have missed out when it comes to the means to fight the pandemic. And in wealthier nations, it has been the least well off who have suffered most. The panel believes that the systemic and structural inequalities which have been made worse by the pandemic must be the lens through which we view all of our work. This is true whether we look at the unequal impact of the virus on marginalized communities, such as migrant workers and indigenous communities, or at the unequal access to testing, supplies, medicines, and vaccines. We are grateful to scientists for developing vaccines in record time. As 2020 ended, we felt hope. But the panel is discouraged and frankly disappointed by the unequal plans for vaccine rollout. Tens of millions of doses of vaccines are already available in some of the wealthiest countries. But based on current plans, vaccines will not be widely available across the African continent, for example, until 2022 or even 2023. As our report says, where you are born should not be the factor that determines your place in the vaccine queue. As former leaders of our countries, Prime Minister Clark and I understand the massive political pressure every leader is facing to vaccine all of their own people first. But it is unacceptable for wealthy countries to be able to vaccine 100% of their population, while poorer countries may do with only 20%. It is no exaggeration to say that we are at risk of creating a vaccine distribution system grounded in inequity. We cannot let this happen. The panel believes that fairness based on public health needs, not narrow national interests, should determine who gets access to the vaccine and when. Speeding up vaccination for all and investing in the frontline health workers and primary healthcare systems that deliver them isn't just the right thing to do. It is the smart thing to do. No one is safe until everyone is safe. Second, let me now underscore another key finding in the panel's report. The panel believes, like many of you, that major changes in the system which should protect global health are needed. After every new pandemic or other major health threat, there are many evaluations which come up with dozens of recommendations. They are nearly too numerous to count. and too few of them have been acted on. The panel expresses deep concern at the level of action which has followed earlier reports, and we hope member states share that concern. This mistake cannot be made again. In November, member states challenged us to make recommendations which were implementable, costed, and had clear timelines. We were challenged to be unafraid to speak uncomfortable truths. From our interviews and meetings with member states, we know that there is recognition of the need for action. This is a unique opportunity born out of the gravity of this crisis to reset the system. Real change in global and national health systems that will benefit every country and every citizen must challenge the status quo. That means we need to listen more to healthcare workers and heed their advice. It means drawing on the knowledge of those who manage local responses, such as mayors, and it means not only hearing, but also acting on what people on the margin of society are telling us. Their experience of what goes wrong will show us what we must do to make it right. Our report makes it clear that the world is more reliant on an effective WHO than ever before. But while member states turn to the WHO for leadership, they have kept it underpowered and under-resourced to do the job expected of it. For example, many of you have pointed out that if WHO is expected to raise perpetually because assessed contributions to it remain low, then this will come at the expense of its ability to focus on pandemic preparedness and response, among other core priorities. Pandemic preparedness financing has been treated as a cost to come out of a limited official development assistance bucket, rather than what it truly is, a global public good, an investment in our collective future. This unprecedented pandemic has led to unprecedented challenges for our world. If we do not act now, then when? If it is not us, then who? I will now hand back to my co-chair, Prime Minister Kwok.
The report will obviously go into more detail and make a series of concrete and evidence-based recommendations on creating a fit-for-purpose pandemic preparedness and response system. The panel is very grateful to the many stakeholders who continue to provide us with information and ideas, including through the panel's website and including member states. In the interests of transparency, we will continue to post our meeting reports and key materials which we are considering on our website, including written contributions made to the panel. We will also continue to host public exchanges like the one with the global nursing community to which I referred earlier. There's still much to learn and to analyse. We do look forward to the ongoing feedback, comments and suggestions of member states. What we've presented to you is just an interim report on the progress we're making. This is not our main report. The international community is at a crossroads with respect to pandemic threats and responses. The choices which are made in the coming months will show whether our world is determined to be more prepared, more health secure, more equitable, and more resilient. Let me now hand back to you, Chair of the Executive Board, and we look forward to hearing from the chairs of the IHR Review Committee, the IOAC and the GPMB, and to hearing the feedback of the Executive Board. Thank you very much.
Yeah, thank you. Thank you so much, President Sirleaf and Prime Minister Clark. The international health regulations are an essential legal instrument and the foundation of global health security. Even before the pandemic, I had spoken about how emergencies such as the Ebola outbreak in Eastern DRC demonstrated that some elements of the IHR may need review, including the binary nature of the mechanism for declaring a public health emergency of international concern. In August, and in accordance with Resolution 73.1 and the provisions of the IHR, I convened a review committee to examine the functioning of the IHR during the pandemic. This is the first time a review committee has been convened under the IHR. I'm very grateful to the committee for its work over the past few months, and I would like to welcome its chair, Professor Lothar Wieler, to brief the board on its work so far. Professor Wieler, thank you for joining us today, and you have the floor.
Excellencies, Director General, ladies and gentlemen, thank you once again for the opportunity to provide you with an update on the work of the Review Committee on the functioning of the international health regulations during COVID-19. As you know, this committee was convened by the Director General on 8 September 2020 in line with World Health Assembly Resolution WHA 73.1. The committee is composed of experts with a wide range of expertise and with adequate gender and geographical representation. I have the honor to be the chair of this committee and am ably supported by our vice chair, Professor Lucie Bloomberg of South Africa, and our rapporteur, Professor Preben Arvidsland from Norway. Our mandate is to review the functioning of the international health regulations during the COVID-19 response and the status of implementation of the relevant recommendations of previous IHR review committees, and to make technical recommendations to the Director, including any potential amendments. We convened for 16 closed meetings so far, and we continue to work through 3 subgroups: preparedness, alert, and response. I take this opportunity to reiterate my thanks to our 3 subgroup leads. We also convened 5 open meetings when we provided updates on our work and listened to the submissions and questions raised by member states, international agencies, and non-governmental organizations in official relation to WHO. These open meetings continue to be attended by numerous designated representatives. I reported on our progress to the 73rd World Health Assembly on 9 November 2020, and I continue to interact regularly with the co-chairs of the Independent Panel for Pandemic Preparedness and Response and the chair of the Independent Oversight Advisory Committee. Let me now turn to the substance of our work. I invite you to read our interim progress report, document EB 14819. It details our preliminary findings as of December 2020 which were reached following numerous interviews, discussions, and the review of a wealth of documentation. Let me point out the most important ones. A. Member states and experts overwhelmingly support the IHR as a cornerstone of international public health and health security law, but several areas need improving if we are to be better prepared for the next pandemic. While we have not finalized our article-by-article assessment, there is a growing belief in the committee that most of the necessary improvements can be achieved through more effective implementation of the existing provisions of the IHR and do not require at this point changes to the design of the IHR. B. National IHR focal points need to be further empowered, including where necessary through national legislation. National focal points play a critical role in the timely sharing of information, but their limited authority and status often lead to delays in notification. The committee noted that effective IHR implementation requires many functions that are not within the narrow mandate of the national IHR focal points, such as multi-sectoral coordination for preparedness and response and collaborative risk assessment. The absence of a dedicated national entity with sufficient authority and a clear mandate to take ownership and leadership is considered a significant limitation to effective implementation of the IHR at national and subnational levels. At country level, national IHR focal points need to be integrated in the National Emergency Plan as well as the National Health Committee or similar body. C. The possible need for an intermediate level of alert before a public health emergency of international concern is declared, the FEIC, is also under consideration. The previous review committee on the Ebola response recommended such an intermediate level, but this recommendation was not taken up. The fifth open meeting of the committee on 12 January 2021 discussed issues surrounding the possible introduction of a grading system. The different views expressed by member states and the advantages and potential disadvantages of a new system will be further studied by the committee. It is clear that global preparedness, alert and response actions need to start much earlier and more decisively than they did during COVID-19. But it is far from certain that introduction of an intermediate level of alert would result in such earlier action. The committee is considering how regular global and regional risk assessment can be used better to drive earlier and more targeted response measures at all levels. The aim, the committee feels, should be to react early and strongly enough so as to prevent the need to declare a FEIC. D. Compliance with IHR provisions remains a challenge in several areas, from setting up core capacities to implementing travel measures during health emergencies. The committee is mindful of the lack of teeth in the IHR. We are therefore looking at new ways to monitoring and evaluating adherence to IHR, both in preparedness and response, and to strengthen existing tools without overburdening countries. Considering a peer review mechanism similar to the universal periodic review used by the Human Rights Council may be useful in improving preparedness and response. For example, the universal periodic review has been shown to foster intersectoral coordination and whole-of-government approaches to encourage good practices and to link implementation of its recommendations with other government aid agendas, all of which are vital to strengthening IHR implementation. It is in this context that the Director General has proposed the Universal Health and Preparedness Review initiative, which is currently being pilot tested. E. Last but far from least, political support and resources for IHR implementation remain insufficient and irregular at all levels. In this context, the committee is awaiting further detailed information on the funding mechanisms for IHR implementation. I would like to clearly state my conviction that we need more meaningful cooperation during and in between health emergencies, more transparency, more regular detailed exchange of real-time data and experiences at all levels, more reliability of interaction, and greater speed in sharing data and samples. Fortunately, digital technology supporting such developments is increasingly becoming available, from data mining to find disease outbreaks early, to next-generation sequencing, to follow pathogen around the globe, to virtual conferencing that makes human interaction easier. To come to the conclusion, the deadline for our final report is the 74th World Health Assembly in May 2021. However, as we all know, the COVID-19 pandemic will be far from over in 4 months' time, and therefore our findings and recommendations will not necessarily be complete. Further deliberations may be needed later. Let me reiterate what I said in November 2020 on the occasion of the 73rd Health Assembly. The IHR are your instrument, our instrument of international public health law. Making them work requires giving WHO the tools and the resources it needs to better prepare and protect humanity against public health risks through an effective, coordinated, multi-sectoral and evidence-based public health response. Thank you again for the opportunity to speak to you today, and let me also thank the Director General for the excellent support provided by the WHO Secretariat to this review committee.
Thank you. Thank you so much, Professor Wille. When the WHO Health Emergencies Program was created following the West African Ebola outbreak of 2014 and 2015, member states rightly saw that accountability would be essential for the success of the program. The Independent Oversight and Accountability Committee was established to provide oversight and monitoring of the development and performance of the program and to guide the program's activities. The IOSCE has been playing this role successfully for several years before the pandemic and during it, and has contributed to strengthening the current emergencies program. We're very grateful to the committee for its work, and I welcome its chair, Dr. Felicity Harvey, to update the board on the IOSCE's work and findings so far. Dr. Harvey, thank you for joining us today, and you have the floor.
Honourable Chair, Director General, Your Excellencies and distinguished delegates. Thank you. On completion of its second term of office, the Independent Oversight and Advisory Committee for the WHO Health Emergencies Programme, the IOC, submitted a 4-year review, document A7310, to the resumed 73rd World Health Assembly in November 2020. Under the revised terms of reference for its third term of office, from May 2020 to May 2022, IOC reports annually to the World Health Assembly. However, given the ongoing COVID-19 pandemic, the committee decided that it would be helpful to provide a verbal report to this, the 148th session of the Executive Board. As the DG said, IOC is mandated to oversee WHO's work in emergencies, and the committee has therefore been tracking progress made in implementation of our recommendations contained in both the report, the interim report for COVID-19 from January to April 2020, and the 4-year review report. We will continue to monitor WHO's performance in emergencies and will provide a comprehensive annual report to the 74th World Health Assembly in May. However, today we wish to flag up some issues and concerns. The committee recognises the tireless efforts that member states and the Secretariat have made in response to COVID-19 and calls on all parties to work together to ensure that all countries have equitable access to therapeutics and vaccines. IOC is pleased to note the progress made since its interim report, and particularly the speed and quality assurance of the WHO's technical guidance. The committee reiterates that member states supported by WHO need to fully implement all public health measures, and surveillance, testing and research efforts should be strengthened to rapidly assess the impact of the new SARS-CoV-2 variants. From the outset of the WHO Health Emergencies Programme, IOC has advised the Director General to safeguard the programme's managerial authority and autonomy against politicisation. The last IOC report, published in November 2020, reiterated that the WHE programme should operate on a principle of a single structure, single budget, single staff work programme, common results framework, with clear reporting lines across WHO headquarters and all regional offices. IOC urges the Global Policy Group to further clarify accountability for health emergency management and recruitment of senior emergency personnel between the regional directors and the executive director of the WHE programme, and to institutionalise the managerial authorities and processes already agreed. In the context of transformation, IOC recommended that there should be dedicated teams for emergencies within the centralised functional divisions, such as human resources, communication, resource mobilisation, procurement and security, with a dual reporting line to the WHE programme, and that key performance indicators should be established to track their impact on WHO emergency operations. The committee is pleased to see there is headquarters management consensus on this recommendation, and its implementation is underway. IOC has repeatedly expressed its concern regarding the lack of predictable and flexible funding of the WHE programme, competing priorities, heavy dependence on a limited number of donors, and the current mechanism for the contingency fund for emergencies. The committee welcomes member states' commitment to and ongoing discussions on the adequacy and suitability of WHO financing. But we reiterate our recommendation to allocate an increased proportion of WHO core flexible funding to the WHE programme, and we express our particular concern at the low level of preparedness funding. While acknowledging WHO's efforts in making security a corporate function and in developing the security strategic plan, the committee is deeply concerned at the lack of clarity in accountability and reporting lines for WHO security functions between field, country, regional office and headquarters. As WHO's role in major emergencies grows and its operations expand in conflict settings, it is of paramount importance to institutionalise a functional security apparatus with a clear accountability framework across the entire organisation. Following the allegations linked to the Ebola response in the Democratic Republic of the Congo, Dr. Tedros established an independent commission to conduct a fact-finding process to investigate specific allegations and recommend measures to prevent sexual exploitation and abuse. While waiting for the findings of the independent commission, high priority should be given to identifying areas of high risk for potential exploitation and abuse where WHO is currently operating, and to immediately implement preventive measures, drawing upon the guidance provided by the Interagency Standing Committee on Prevention of Sexual Exploitation and Abuse and lessons learnt by UN agencies and other humanitarian partners. IOC recommends that WHO adopt a people-centred approach in preventing and addressing such incidents in the future by strengthening existing whistleblower and redress mechanisms, building community trust, and putting in place the right local partnerships in high-risk settings to ensure that the conditions for sexual exploitation and abuse do not persist. Overall, The committee is reassured by the action taken so far by the Secretariat and will closely monitor and measure progress made in putting the recommendations issued in our previous reports into practice. We reaffirm our commitment to providing oversight of WHO's work in emergencies and will report to Member States. IOC also welcomes the reports of the Independent Panel for Pandemic Preparedness and Response and of the Review Committee on the Functioning of the International Health Regulations during the COVID-19 response, as well as the Global Preparedness and Monitoring Board statement. IOC is committed to supporting their ongoing work. I thank you.
Thank you. Thank you so much, Dr. Harvey. In my remarks yesterday, I said that we have long known the next pandemic was a question of when, not if. In 2018, in response to recommendations by the UN Secretary General's Global Health Crisis Task Force, and as part of WHO's transformation, WHO and the World Bank joined forces to establish the Global Preparedness Monitoring Board to provide independent and comprehensive appraisal of global preparedness and response capacities. In September 2019, just 3 months before the first case of COVID-19 were reported, the GPMB published its first report called A World at Risk. Last year, the board published its second report called A World in Disorder. I'm very grateful for the board's work, and I'm pleased to welcome its co-chairs, Dr. Gro Harlem Brundtland, former Prime Minister of Norway and former WHO Director General, and Mr. Elhaj Assi, former Secretary General of the International Federation of the Red Cross and Red Crescent Societies. Dr. Brundtland and Mr. Assi, thank you so much for your work, and you have the floor.
Thank you for inviting us to speak here today. The Global Preparedness Monitoring Board, an independent monitoring body, was established in 2018 by the WHO Director General and the President of the World Bank in response to a recommendation from the UN Secretary General's Global Health Crisis Task Force. We comprise political leaders, heads of agencies, and international experts. We advocate at the highest political levels and across sectors for greater investment and engagement in health crisis preparedness. Our first report, A World at Risk, was published in September 2019. The report warned about the risk of a pandemic of a respiratory pathogen that could kill millions, wiping out 5% of the world's economy and creating widespread havoc. We found the world was unprepared. We warned of the inadequacy of systems and financing needed to detect and respond to health emergencies. We urged political leaders to implement the international health regulations, to improve multi-sector coordination, and to invest in vaccine and therapy development. In COVID-19, our worst fears were realized. The world was indeed unprepared and the impact enormous. In our September 20 report, A World in Disorder, we describe how the pandemic has exploited a world in disarray with catastrophic health, economic, and social consequences. COVID-19 has again illustrated that pandemic preparedness must reach far beyond health to ensure all impacted sectors stand ready, indeed, the economy at large. We have learned that global preparedness is greater than the sum of national preparedness. In an increasingly interdependent world, it is in every nation's interest to cooperate. Nations must invest in common goods and ensure mutual accountability. We have learned that our financial institutions, including the World Bank and the International Monetary Fund, do not have mechanisms to fund global public goods for R&D, including for WHO, and for vaccines for unknown pathogens. This needs to be addressed in a new framework for global health security. A key lesson for all of us is already clear, and it applies to all levels of political leadership in countries large and small. Our multilateral institutions now need to be considerably strengthened, and WHO is a critical part of this challenge. We should all be aware that a review does not necessarily lead to improvement. It may, in fact, lead to the opposite, especially when urgent actions are required. For example, the last review of the international health regulations, a process we initiated during my time as Director General of WHO, may actually have weakened the authority of the Director General. Pandemic preparedness can yield immense returns on investment, but our current development assistance funding models are woefully inadequate, both in scale, predictability, and in form. We require new approaches, so the world without untoward delay can mobilize financing common goods, preparedness, and immediate response. I now give the floor to my co-chair, SC, to present the urgent actions that we call on member states and the executive board to take.
Thank you very much, Gro. Mr. Chairman, Dr. Tedros, Excellencies, colleagues and friends, currently our most urgent focus is on ending the COVID-19 pandemic, but it is essential to prepare for tomorrow as we respond today. We have learned lessons from COVID-19 at devastating human cost. We must now implement the fundamental changes to preparedness, or another catastrophic pandemic is sure to follow. Member states must ensure that the necessary actions are taken. To end the COVID-19 pandemic, countries must commit to equitable access for vaccines. This is both a moral and a public health imperative. Our pride in the groundbreaking speed of COVID-19 vaccine development is only justified if all countries benefit equally and at the same time. We urge member states to ensure that vaccines and other countermeasures are allocated according to need and impact in stopping this pandemic. Access must be fair and equitable, not based on ability to pay. We call on member states to support the COVAX initiative so that it can provide this access. At the same time, countries must face the future. Bold reforms of global health emergency preparedness and response must be implemented without delay. WHO and the multilateral system must be strengthened. COVID-19 has exposed the limitations of our global institutions, but we do not need new institutions. We need to empower the ones we have. Inadequate and unpredictable financing threatens the WHO's capacity to play a central role in global health emergencies and to deliver on its broader mandate. Member states must address this need and must strengthen the international health regulations to ensure they are fit for purpose. We must also change the way we pay for preparedness. We call on WHO and its member states, working with the United Nations and international financing institutions, to develop mechanisms for sustainable, predictable financing. These mechanisms must support national capacities and enable the development of global goods. We also need financial mechanisms to mitigate and prevent the economic and socio-economic consequences of pandemics and epidemics. Effective pandemic preparedness crosses borders, eliminates silos, and ensures that both lives and livelihoods are protected. We call for a summit on global health security to agree on an international framework for health emergency preparedness and response. This framework should consolidate and harmonize our existing mechanisms and facilitate coordination between actors and stakeholders, providing platforms for multi-sectoral engagement and community involvement and strengthening capacity and accountability. Over the years, there have been many calls for adequate financing, robust systems, and stronger governance. But we must remember that the decision to prioritize health security and invest in preparedness is a political one. The world will not be safer unless we have leaders who commit to preparedness based on solidarity and sustainability. This is a defining moment for humanity. As we respond to COVID-19, we must also take the necessary steps to avert a future pandemic. We must face our vulnerabilities and harness our collective strengths with a common resolve, namely, that never can this happen again. Thank you very much.
Thank you. Thank you so much, Dr. Brundtland and Dr. Asi. And now back to Tim.
Thank you very much, Director General. On behalf of the Chair of the Executive Board, Dr. Harsh Vardhan, I would now like to give the floor to Dr. Mike Ryan, Executive Director of WHE, to provide some comments on strengthening WHO's global emergency preparedness and response. Mike, you have the floor.
Thank you, Tim, and thank you, Chair. Just for some context, the officers of the board had asked the Secretariat to prepare a paper which you have in your files, EB 1488E. This was asking the Secretariat to provide an overview of the emerging themes and the emerging issues and initiatives needed to strengthen WHO's global emergency preparedness and response. At that time, many member states were working together in different groupings and being brought together and convened by the European Union in the hope of bringing together a member state sponsored paper on the same matter. And I believe the member states have put forward a paper, a conference paper, EB 148.4, which will be considered in this session, and therefore the member states, the executive board, will be able to make some decisions as how to move forward. So if you could please see this presentation purely as a way of feeding your thinking and your ideas for the following discussions, rather than a specific proposal by the Secretariat. Next slide, please. The Director General and the chairs have outlined the roles of the various committees. The Independent Oversight and Advisory Committee and the Global Preparedness Monitoring Board are ongoing multi-risk mechanisms for consultation and advice that advise the Director General and the World Health Assembly on all matters related to global preparedness and response. And obviously we have the Review Committee on the functioning of the IHR. We heard from Professor Wheeler, and the IPPR, and we heard from the two co-chairs. But in addition to that, there have been a whole series of consultations, engagements, reviews at the EU, G7, G20, G77, United Nations. We've seen national assessments, regional reviews and mechanisms being put in place, assessments, committees within parliamentary systems, and a whole series of different ways of looking at both national, regional and global preparedness. What we're trying in this sense to distill from the perspective of strengthening WHO's and the global component of that is just to distill out some of the key themes and the key areas that have emerged. Next slide, please. So the key areas for consideration, and in a sense, I heard Al-Haji IC and other previous speakers speak to some of these components. And IC just said the world will not be safer if we do not. And in a sense, I suppose you look at this, the world will not be safer if we don't do the following things. To create an unbreakable chain of strengthened national health emergency preparedness and response systems. I think everybody accepts that the basis of global health security is strong national systems connected in an effective way. One can argue that you want to bypass those systems and have a system that's more direct, but it's very difficult to think about a world in which that will happen without the nation state being a central piece in protecting the health of their citizens and engaging with others in the pursuit of that global objective. We obviously need an enhanced global early warning alert response system, and really that connects all of those national systems and uses the state-of-the-art 21st century technologies I mentioned in the previous session. The epidemic intelligence from open sources and artificial intelligence-driven platform and ecosystem for the collection, collation, and intelligence-driven decision-making for health emergencies. Thirdly, and again, this has arisen again and again in various reviews, we need a global health emergency end-to-end supply chain and logistics system. However, there are specific qualities to such a system. Because much of the equipment in such a supply system is highly specialized, is very often adapted to the emergency in which it's been used. You have a very high scientific pre-qualification component to that, specifying the disease commodity packages, the quality, the validation of that equipment, the testing of new equipment, the innovation. So innovation, testing, pre-qualification, manufacturing, supply. This isn't just about supply. Everything broke in this COVID-19 pandemic. It was not just a supply issue. There were manufacturing issues, there were raw material issues, there were distribution issues, there were air issues, there were competitive issues between member states. It wasn't just about logistics. It's a much more complicated challenge, and it is going to require a comprehensive, and I would dare I say it, complicated solution to make it work. We've learned many of those lessons working with the World Food Programme, UNICEF and others within the UN supply chain mechanism, but many more lessons are being learned at national and regional level. We need a global health emergency workforce to support and surge, especially in a pandemic. It's not as relevant, but we've seen thousands and thousands of health workers being able to redeploy within the nation state or between nation state. And we've seen in this pandemic, it has not been even. There have been areas within countries or countries within regions that have been deeply affected. And if they had got more assistance more quickly, if we had been able to move people more quickly into those locations, we could have saved more lives. So we just don't need a dynamic data system and a dynamic logistics system. We need a dynamic workforce, cross-trained, mutually accepted, and deployable to wherever they're needed at the time they're needed. We need comprehensive platforms and communities of practice to manage misinformation and disinformation. The infodemic has nearly been as tough as the pandemic in many cases, and these kinds of misinformation and disinformation cause harm. They undermine evidence-based approaches. They undermine personal and community compliance with public health measures, and our work to enhance and improve how we operate on the infodemic will be very important in the future. Next slide. We need, and Maria and others are here with me, Sami and others, we have to work on the global platforms, the networks and standards to harness the knowledge, to continue to harness the knowledge and expertise, translating evidence into effective health emergency policy for especially epidemic, pandemic-prone diseases, high-threat pathogens, emerging zoonosis and biorisks. That in itself is a dynamic cycle of information gathering, assessment, creation of guidance, disseminating, implementation, and review. It requires internal, multidisciplinary action, external networks, and the participation of all around the world who can contribute to this process. This is in itself a massive global good. that needs to be developed and delivered consistently and reliably on behalf of all member states. We need to enhance and expand the networks and mechanisms and incentives for the sharing of pathogens, biologic samples and genomic data. The Director General's announced initiative on the BioHub addresses part of that. We've had previous experiences, positive, with the PIP framework. We need to build on all of those experiences in order to ensure that that material and these data move quickly. We need to continue on the platforms created like the Research and Development Blueprint for Epidemics and ensure that we have accelerated research and innovation for epidemics between, before, during and after. This cannot just be a matter of starting this work during. We have benefited massively from the Research and Development Blueprint for Epidemics. The fact that we had target product profiles for coronaviruses and for disease X in advance, and myself and Dr. Soumya Swaminathan, who sits beside me, co-manage that network, and we're so proud to work with so many of the external institutions and the researchers around the world and our wonderful R&D Blueprint team. But that team is fragile, that alliance is fragile, underfunded, and requires significant investment to answer the demands of our member states. We need a coordinated global platform to ensure rapid, equitable access to the fruits of research and innovation. Bruce Railwood is sitting to my left. The ACT Accelerator is a model, it's a platform. We may need it again, so we need to be very careful that when this pandemic ends, that if we're putting ACT away, we put it away in a way that we can rebuild it quickly, or we find ways to maintain those relationships and those systems that we've worked so hard under the leadership of all of the agencies, particularly under Dr. Tedros' leadership to drive. And we need, finally, and everyone I think has said this in every review, sustained, predictable funding for health emergency preparedness and response. I will put it to you plainly, Member States, and you said it, and others have said it. There is a massive gap between the rhetoric on funding and the reality of the funding that this organisation and our partners receive to deliver on global health security and global health emergency preparedness and response. My grandfather used to say, you get what you pay for. And in this case, we have not invested enough to deliver a system of high enough quality, predictability, that can deliver on what we all want for our citizens. Prevention, prediction, detection, and early response, and a planned recovery to any of these agents that threaten our collective security. Next slide. And last slide, you'll be glad to hear. So for the world to move forward, again, I'm here more mouthing what we've seen and analysed from the various reports. Everyone in the previous speakers has spoken about political will and international cooperation being prerequisites to move forward. We need strengthened accountability in the pandemic preparedness system, building on the IHR, accountability and performance for all, at all levels. We need sustainable and predictable financing. We need an empowered and resourced WHO at all three levels of our organisation. And the chair of the IOAC spoke about that. But that not only focuses on its capacities in global health emergency response, but also coordinates global pandemic preparedness. And obviously a multi-sectoral approach, and there are many have spoken about the international financing institutions, but the overall approach of taking a One Health approach and looking at all of the sectors and all of the agencies who can contribute to a healthy planet, to healthy animals, and to healthy people, and working very closely with the Deputy Director General to realise the vision that the DG has for the One Health Council. So that's it from my side there, just a sense of bringing together some of the issues that have arisen in all the informal and formal processes as a way of informing the follow-up discussion on how the EB wishes to move towards the World Health Assembly. Tim, you have the floor back.
Thank you very much, Mike. I now, through the chair, give the floor to the... excuse me. I now hand the floor, Your Excellency, back to the chair, Dr. Harsh Vardhan. Thank you, Chair.
Thank you, dear. The floor is now open for discussion. I would like to request that the Secretariat moderate the discussion on the virtual platform. Secretariat, you have the floor once again.
Thank you, Your Excellency, Mr. Chair. May we kindly remind those member states wishing to make an intervention to please raise their hand in the Zoom platform. I should now like to call upon the distinguished delegate from Austria to be followed by Botswana. Thank you. Austria, you have the floor.
Thank you very much, Mr. President, Director General. I have the honor of speaking on behalf of the European Union and its member states, as well as on behalf of the candidate countries, Turkey, the Republic of North Macedonia, Montenegro and Albania, as well as Ukraine, the Republic of Moldova and Armenia, who all aligned themselves with this statement. We thank the Secretariat for its report on WHO's work in health emergencies. It reminds us that there are concurrent health emergencies on top of the COVID-19 pandemic that WHO is continuing to address, of which many are protracted crises where staff is also often at risk. We commend WHO staff for their tireless work, their courage, and their commitment to continuously improve WHO's emergency program. In this regard, we recall our expectations for a transparent and regular follow-up by the Secretariat on the progress of implementation of the IOAC's recommendations, including providing all WHO representatives with proper training, staffing key positions, especially in priority countries, and ensuring that the WHE program operations are transparent and free of collusion, fraud, corruption, and other types of misbehavior. To the evaluation mechanisms, we cannot stress enough the importance of your work. We are convinced that WHO must remain the lead international agency on global health. That is why we need a stronger WHO within a stronger multilateral system. We acknowledge that expectations from member states generally outweigh the current WHO capacities. The international community needs to be on board to implement bold changes. This includes taking ambitious but realistic decisions regarding the future biannual budget and sustainable financing in general, while enhancing transparency and accountability of the organization. We thank the Secretariat and the IHR Review Committee for their reports and the open meetings organized since November. We recall the great importance we attach to IHR. We must admit, however, that the world as a whole was not prepared for this pandemic. We need to rethink prevention, control, and response to global health crises. That is why the EU and its member states stand ready to explore ways to reinforce IHR implementation, including an effective system of compliance evaluation. We also stand ready to engage in strengthening member states' accountability, prerogatives of WHO, and equitable access to health technologies, leaving no one behind. We also want to stress the importance of transparent, swift, reliable, and timely communication. It is a two-way process where trust should be the ultimate cornerstone. We're ready to engage in a discussion on how member states can be better associated to decision-making when unusual health events of concern are detected and when PHEICs are declared, including by enhancing the role played by the EB in this regard. Ultimately, the responsibility for change lies in the hands of the member states. This is why the EU welcomes the adoption of a decision which paves the way for a resolution to strengthen WHO's work in emergencies for adoption at the next WHA. The EU is pleased to inform you that a draft resolution proposing a way forward to address the recommendations of the evaluation groups will be shared soon. We're looking forward to working together with all member states in close cooperation with the evaluation mechanisms and the Secretariat in an inclusive, constructive, and transparent manner. Thank you very much.
Thank you. And now to Botswana, to be followed by the Republic of Korea.
Thank you very much, Chairperson. Botswana is pleased to deliver this statement on behalf of the Africa region member states. We welcome the report on the public health emergencies and response. The region acknowledges the progress made and commend the WHO for responding to 60 graded emergencies, of which 8 were WHO Grade 3 and United Nations Interagency Standing Committee Level 3 emergencies. These include two public health emergencies of international concern: the outbreak of Ebola virus disease in the Eastern Democratic Republic of Congo, and the global pandemic of coronavirus disease during the period January to August 2020. We also commend the WHO for the management of emergencies through the WHO Incident Management System. The ICM has allowed for the rapid establishment of structures at country, regional, and headquarter level, as well as supported the quick release of funds within the 24 hours through the Contingency Fund for Emergencies. This has translated into the support of national governments to increase the quality and coverage of health services through strengthening primary health, secondary health, and primary hospital care by deploying mobile teams and reinforcing health facilities, improving surveillance and early warning system, conducting vaccination campaigns, distribution of medicines and supplies, and training of health workers. As reported, our region experiences the majority of the WHO higher graded public health emergencies. Thus, we request the WHO to prioritize allocation of resources to improve capacity, to enable member states to detect events early, and for emergency preparedness and response. We welcome the WHO benchmarking tool to support building core capacity under the international health regulations. Chairperson, our region notes that the quest to deliver quality health services during the health emergency, especially in the African region, continues to be hindered by limited funding, humanitarian and human resource capacities, mass population movements during such crises, and ongoing insecurities. This therefore calls for the need for the WHO to engage political leadership in countries, the African Union, and all major relevant stakeholders so that control and containment of health emergencies in challenging environments can be achieved. Chairperson, we also thank the WHO Regional Director for the support of the member states in the IHR joint external evaluation exercise and submission of the self-assessment annual report on monitoring and evaluation. As reported, all state parties are performing better than in the previous reporting period in key capacities such as surveillance, laboratory, coordination, and IHR national focal points functions. However, we request the Secretariat to continue to improve the human resource capacity, which did not show improvement in the reporting period. Our region also looks forward to the rollout and expansion of the national resource mapping and impact analysis on health security investment. This should be accompanied by the WHO tool to identify all financial and technical resources available for capacity building for the regulation for implementation of COVID-19 preparedness and response plans, in line with the recommendation and priority action arising from monitoring and evaluation of fulfillment of the regulations. Finally, Chair, the African region welcomes the second progress report of the Independent Panel for Pandemic Preparedness and Response. And we thank the panel secretariat for their work. We look forward for the next report to be presented at the 74th WHA on the progress and lessons learned from the international response of the COVID-19. I thank you for your kind attention.
Thank you. And now to the Republic of Korea, to be followed by Tunisia.
Thank you, Chair. I have the honor to deliver this statement on behalf of the 8 core members of the G4IDR, the support group for global infectious disease response, namely Kenya, Mexico, Morocco, Peru, Singapore, the Republic of Korea, Turkey, and the UAE. We appreciate the update from the IPPR, the IHR Review Committee, and the IOAC. We thank the chairs for their leadership in guiding the important mandate of the respective review mechanisms, which will be the cornerstone of our collective efforts to build a more resilient and responsive global health system in the coming months and years. Following up on our joint statement made at the 5th special session of the EB meeting, we submitted our written recommendations on the IHR improvement to the IHR Review Committee last December. The group highlighted the following areas for consideration. Member States consider improving and actively carrying out periodic joint external evaluations of national core public health capacities with clear relations between the evaluation and actual preparedness. Strengthening information sharing mechanism of the IHR by various ways such as improving criteria and guidelines. Developing a real-time platform, standardizing the tracing of contacts upon notification of a possible fake event, and strengthening consultation between member states under Article 43. Establishing a principle on the facilitation of essential movement of people in line with IHR's objective of avoiding unnecessary interference with international traffic. Proposing that the Director General of WHO should have an intermediate option in declaring a fake based on more transparent deliberation of the Emergency Committee. Providing more detailed guidelines to Member States on using digital technologies for public health purposes in accordance with IHR provisions on human rights and personal data. Lastly, encouraging WHO and Member States to make sure that IHR focal points are well equipped for fulfilling their mandate. Let me conclude by reaffirming our strong commitment to actively engaging with all relevant stakeholders to better support WHO deliver on its mandate. In this regard, we look forward to the final recommendations from IPPR, IHR Review Committee, and IOAC. At the same time, we will continue to closely work with other member states to strengthen preparedness and response for health emergencies. Thank you, Chair, and we wish you all fruitful deliberation today. I thank you.
Thank you. And now to Tunisia, to be followed by Indonesia.
شكرا السيدة المنسقة. أتشرف بإلقاء هذه المداخلة.
Thank you, moderator, and thank you, Chair.
الشرق المتوسط. نيابة عن دول.
I'm making this statement on behalf of my region. I would like to begin by thanking the Director General, and I would also like to thank the committee for the job of work that they have done. I'm referring, of course, to the committee that has considered IHRs. We would like to thank the Secretariat for all of the support given to the committee, the review committee for the IHRs. We would also like to thank the committee for all of the comments made and for all of the results achieved.
تقدم تنفيذ القدرات المطلوبة بموجب اللوائح الصحية الدولية على مستويات مختلفة في بلدان الإقليم.
In our countries, we have focused our work and our efforts on a number of different levels. However, the COVID-19 pandemic has highlighted a number of areers where there are gaps in what we have been doing, in particular in our preparedness and response. For that reason, we have developed national plans. However, implementation of those national plans has differed from one country to another.
وسوف يتناول تحديث الخطط وضمان الإدماج الكامل في إطار تقوية النظم الصحية العادية.
What we would now like to do is to update the plans that we have and to strengthen our health systems. We recognize that we need to do that in order to reflect a number of the points made by the committee itself.
وتحتاج البلدان التي تشهد حالات طوارئ إنسانية طويلة الأمد.
In some of our countries,
حيث يتلاقى بها
we
have very difficult humanitarian situations, and those countries need help. They need assistance because they're having to tackle humanitarian crisis alongside this health crisis.
حيث يتلاقى بها الأمن الصحي والاحتياجات الإنسانية وينطبق ذلك خاصة على
Indeed, those countries really have humanitarian needs. And I'm thinking in particular of Middle Eastern countries. 43% of all of those requiring humanitarian assistance throughout the world are in the Middle East.
ونرحب بالنتائج الإضافية التي تسفر عليها المراجعة الشاملة للصحة والتأهب.
We would like to commend the results that have been presented on preparedness and response, and we thank all of those involved in the process. Thank you.
ونحن نشجع على اتخاذ خطوات إضافية لتسيير الإبلاغ عن البيانات الوبائية في الوقت.
We would just like to add that we think further measures should be taken to allow us to respond to epidemics more easily in future in a way that is more transparent. We also believe that we need standards and norms for exchanging data. This is particularly important when it comes to trade, to travel, and transport, and ensuring that the health situation throughout the world is properly taken into account.
ونرحب بالدعم الذي تقدمه الأمانة للنهوض بالجهود الوطنية.
Alongside that, we wish to applaud all of the support we've received from the Secretariat in supporting national efforts to improve early warning systems so that we can draw attention to risks and do that in different socioeconomic circumstances.
ويشمل ذلك مكافحة وبائيات المعلومات المضللة كما أن مفهوم استحداث مستوى متوسط
means that we have to fight against fake news. We also have to tackle the infodemic.
كما أن مفهوم استحداث مستوى متوسط من التنبيه عند حدوث طارئة صحية عامة مسببة للقلق الدولي.
We do, however, need a minimum level of warning when it comes to health emergencies. This is very important, and that I think is an area where there is improvement to be made.
ونعتقد أن النسخة النهائية من تقرير اللجنة سيكون مهماً للنهوض بأمننا الصحي الجماعي.
We believe that the final version of the committee's conclusions to be produced will be extremely important.
وفيما يتعلق بورقتي عمل المنظمة في مجال الطوارئ الصحية فإننا ملتزمون بتعزيز التأهب للطوارئ والاستجابة لها.
Now, on the document before us on WHO's work in health emergencies, we certainly have worked on preparedness and response to public health emergencies.
ونلتمس دعم المنظمة المستمر في عدة مجالات.
We would now then call for support from WHO at several levels.
وبالنسبة للبلدان التي تشهد حالات طوارئ إنسانية كبرى ندعو المنظمة إلى المساهمة.
For countries that have significant humanitarian emergencies, here we would call upon WHO to make a more effective contribution to capacity building, to allow those countries to ensure national level response.
بما يشمل نظم الرعاية الطبية الطارئة ويجب دعم
البلدان التي تشهد حالات طوارئ طويلة الأمد. And that means that we need in particular to support those countries that are living with long-term humanitarian crisis.
لتعزيز الصلة بين العمل الإنساني والتنمية والسلام.
That needs to be done if we are to promote the link between humanitarian work, development and peace.
بهدف الاستجابة بفعالية للأحداث الحادة.
The goal
وتوسيع نطاق
is to provide an effective response to these crises. We also want to ensure better health coverage and to ensure that the health coverage we have is more effective.
وإرساء الأساس لتعافي النظام الصحي على المدى الطويل.
In doing that, we want to lay the foundations for health systems in the long term.
ثانياً تقترح الورقة الخاصة بتعزيز تأهب المواطن.
Moving on to another point. The document on public health emergencies preparedness and response at global level is a document that focuses on 10 main levels.
ونحن نقرها كلها وسوف نضيف إلى هذه المجالات.
We recognize all of these levels of work But we would also add the need to promote and strengthen capacity
تعزيز القدرات على إدارة الطوارئ الصحية على المستوى القطري
especially
مع
when
تطبيق
it
نظام
comes
إدارة
to
الحوادث على
management of health emergencies at regional level.
الاستفادة الكاملة من
In doing
مراكز
that, in
عمليات الطوارئ
managing those emergencies, we think we need to take a more coherent approach.
فضلا عن دراسة تفصيلية لدور التدابير الاجتماعية والقيود على التنقل في
And we
إدارة
would like to
الجوائح.
see detailed studies into obstacles to mobility at times of pandemic.
ونشكر الأمانة العامة على التقارير الثلاثة ونشكركم
Thanks are due to the Secretariat for the 3 documents presented, and I thank all of you for your kind attention.
Thank you. And now to Indonesia, to be followed by Bangladesh.
Thank you. We thank the Secretariat for the report and appreciate the work of WHO in supporting the member states to respond to health emergencies. We appreciate WHO's support in responding to poliovirus type 1 outbreak in Indonesia, which declared over by the International Health Regulation Emergency Committee in March. Indonesia take note the IHR Review Committee report and reiterate the support for the regulation as a cornerstone national practice and health security. We also note the interim report of the independent panel for the pandemic preparedness and response and are open for further discuss recommendations in the report. In doing so, my delegation would like to emphasize the following. The finding of lack of equitable access to COVID-19 due to the narrow national interest, economic power, and geopolitical stability of our collective concern. And we need to support multilateral process to coordinate and monitor global health emergency preparedness and response that can be done through a stronger multilateral leadership, sustainable and predictable funding, and a stronger global health system. The panel should continue to look deeper into the various economic impacts of the pandemic and the lessons learned that could be gathered for future global action. Regional response also needs to be strengthened. Therefore, the panel could also derive lessons from regional mechanisms if countries and regions face their own unique challenges with the panel can take into consideration. Preparedness is key. Therefore, the community should continue exploring possible measures or recommendations to strengthen detection and surveillance systems to enable real-time data gathering and provide timely information for countries to react decisively. On the role of the IHR National as noted in the report in the structure of national focal point. In this regard, the Secretariat should provide guidance to strengthen and harmonize the effort to be more proactive. We also support the exploration of various initiatives to further system of compliance evaluation such as the universal health and preparedness and ready to come with the importance for a type specimen subsequent information and finding. However, several key principles such as inclusive fairness and equity in benefit sharing as well as the utilization of intellectual property rights need to be taken into consideration in the development of such mechanism. I thank you.
Thank you. And now to Bangladesh, to be followed by India.
Thank you. Thank you, Mr. Chair. We take note of the report of Director General on WHO's work in health emergencies. We thank the Director General and his team for providing us with the detailed updates on their efforts to extend maximum possible assistance to the governments to contain and come out of this health emergency. In this connection, we note the intervention of the distinguished co-chairs of the Independent Panel for Pandemic Preparedness and Response, and subsequent presentations by the chairs of IHR Review Committee and the chair of IOSC. Mr. Chair, the governments across the continents have been grappling with the health emergencies created by the COVID pandemic. We share an observation made in the report that the risks of a crisis like COVID-19 pandemic were known but were not addressed. It is indeed a matter of great concern. More than ever before, we realize that neither are the governments nor is the WHO equipped with or prepared for to predict, prevent, and respond to multi-country outbreak of the diseases. To prevent the recurrence of such crises, WHO must continue to work with all stakeholders to mobilize predictable and sustainable funding, technical assistance, and technology know-how. There must be an extensive drive as well as committed support to strengthen and prepare the health systems, increase the coverage and quality of health services, and respond to the emergencies, particularly for the most vulnerable countries. Only then we would be able to attain a sufficient and satisfactory strategic preparedness required to face health emergencies like the current one. We appreciate the WHO that has been working very hard in tandem with the governments and international organizations to address the ongoing health emergency. However, WHO also needs to engage with the commercial and business entities to ensure the access to medicines, vaccines, and other auxiliary tools at an affordable price, available at an affordable price by the low and middle income countries. Mr. Chair, we are disturbed by the incidents of sexual violations by some WHO personnel. These incidents have tarnished the reputation of this institution. We hope that WHO will pay due attention to this issue and it will implement the zero tolerance policy on sexual exploitation it has already adopted. Before I conclude, Mr. Chair, I would like to highlight that some conflict-stricken zones, including DR Congo, South Sudan, Syrian Arab Republic, and Yemen, may continue to face untenable health emergencies in the coming days as well. This may upset the global efforts and success to contain the COVID-19 pandemic and other pandemics and endemic diseases. WHO must engage with international and national entities to explore innovative ways to garner global support and mobilize resources to ensure visible and effective remedial responses in the conflict-stricken areas. I thank you.
Thank you. And now to India, to be followed by Kenya.
Thank you, Chair. India has taken note of the report of the Director General on WHO's work in health emergency. India commends WHO on the work done for 6 Grade 3 emergencies, many of which were complex and protracted due to ongoing humanitarian crisis and large-scale displacement of population. We understand that coping with such complex emergency have major challenges in terms of medical, social, public health, and humanitarian issues. We acknowledge that implementing emergency response operations at country level in these countries have been very challenging owing to the unprecedented scale and nature of disruption caused by COVID-19 pandemic. This is a major concern. Various crisis-ridden and vulnerable population deprived of equity, access to healthcare, nutrition, potable water, and sanitation are at risk of getting communicable and non-communicable diseases. This calls for concerted effort of the UN system and WHO to get these challenges adequately addressed. On the issue of vaccine, WHO should strongly push for waiver of IPRs for vaccine in order to ensure equity. Chair, benefits from core capacities built over the years, such as surveillance networks, sentinel sites laboratories, and sample shipment mechanism, could be leveraged for management of COVID. However, it is important to ensure
that reprioritization of efforts in the event of medical emergencies do not cause global disruption to routine surveillance and functioning of global system and capacities. Hence, the organization should provide appropriate guidance to member states to afford higher focus to surveillance system. India has taken note of the progress made so far by WHO in monitoring and evaluation of international health regulation core capacities. However, moving forward, there is a need to enhance capacity of national health systems of many countries in addressing shortfalls in point of entry surveillance as well as preparedness against chemical, zoonotic, and radiological hazards. Thank you.
Thank you. And now to Kenya, to be followed by the United States of America.
Thank you, Chair. Kenya aligns a statement with that made by Botswana on behalf of the African member states. We take note of the report EB 148/17 and EB 148/19 presented to the Executive Board on WHO's work in health emergencies regarding 1. Strengthening WHO's global emergency preparedness and response, and 2. Strengthening preparedness for health emergencies, implementation of the International Health Regulations 2005. We take note of the second progress report of the Independent Panel for Pandemic Preparedness and Response. Kenya is a party to the International Health Regulations and is a member of the Global Health Security Agenda and the support group for the Global Infectious Disease Response. Pursuant to our obligations, we have established centralized outbreak coordination, joint planning, and an emergency response management, communication, and information management structures across all levels of government. Furthermore, our Public Health Emergency Operations Center coordinates operations, information, and resources for strategic management of public health emergencies, and we are currently mobilizing resources to implement the National Action Plan for Public Health Security, which includes public health emergencies, preparedness, and response as a major component. With regards to the review committee on the function of the IHR, we take note of the preliminary findings contained in the interim report, particularly the consideration of the issuance of guidance for events that may not meet the criteria for PHEIC, but nevertheless require an urgent escalated public health response. We look forward to receiving the final report on the committee's recommendations and the possible need for amendments to the regulations. Chairperson, Kenya appreciates the work done so far by the Independent Panel for Pandemic Preparedness and Response. We especially note the summary of the themes emerging from the reports, recommendations, and wish to reiterate the importance of reinforcing the role of WHO and its governing bodies as being central to the future global health governance. In conclusion, we urge member states to continue supporting the various independent review processes so as to ensure that recommendations from the IPPR, the IHR Review Committee, and the IOSC guide future reforms of WHO financing and the global public health emergency preparedness and response architecture. And thank you.
Thank you. And now to the United States of America, followed by Singapore.
Thank you, Chair. The United States thanks the chairs of the Independent Panel for Pandemic Preparedness and Response, the IHR Review Committee, and the Independent Oversight and Advisory Committee for their updates to the Executive Board and interim reports. We align our comments with those of the United Kingdom on behalf of G7 health partners. Efforts to strengthen the WHO must be member state-led, fully inclusive and transparent, and provide a strong platform to consider and implement the recommendations of the IPPR, the IHR Review Committee, and the IOAC. The United States recognizes the European Union for developing the decision point on WHO strengthening and its efforts to lead negotiations in the intersessional period before WHA 74. We are pleased to join as a co-sponsor. All member states should provide input to this process, and we need to take time to listen to all of the recommendations that member states have to offer. It is our duty to provide the WHO and the broader international system with the tools to do its work effectively, efficiently, independently, and transparently. We must rise to this occasion even as we combat the pandemic and resurrect our economies. That is why we need to be sure that the recommendations put forward will be given thoughtful consideration, and any additional funding requests for WHO will be justified and directed at areas where strengthening is necessary, such as pandemic preparedness and response. The United States will work with other WHO member states to strengthen the WHO to make it fit for purpose. Finally, Mr. Chairman, since time is short, we will submit a written statement specifically covering the IHR Review Committee's progress report. Thank you very much.
Thank you. And now to Singapore, to be followed by Argentina.
Thank you, Chair. Singapore supports the draft decision on strengthening WHO's global health emergency preparedness and response. The COVID-19 pandemic is a somber reminder of the importance of building, strengthening, and maintaining the capacities to prevent, detect, and respond to public health risks. Unfortunately, it will not be the last pandemic that the world faces. We support a multilateral approach to health emergency preparedness and response. In particular, the role of the WHO as the world's leading health authority. It is in the interests of all member states that the WHO is more effective in being able to respond more quickly to outbreaks and health crises with broader activation of resources. In this regard, we note the call by the GPMB for a summit on global health security to agree on an international framework for health emergency preparedness. We look forward to hearing more about it. As a co-sponsor of the WHA 73.8 resolution on the implementation of the International Health Regulations 2005, Singapore recognizes the IHR as the only legally binding international law instrument to coordinate a balanced public health response while minimizing disruption to international trade and travel. In response to the IHR Review Committee's call for member states' involvement, Singapore contributed our inputs last year. We note the interim progress report by the committee. While we are still learning about whether the vaccines provide sterilizing immunity and the duration of vaccine-induced immunity, one of the key IHR challenges in the context of COVID-19 would be the global need to verify the vaccination status of travelers. In this regard, an international authentication mechanism may be useful to aid the resumption of global trade and travel. As a core member of the G4IDR, the support group for global infectious disease response, Singapore shares the commitment to work with the WHO and member states for a safer world, where our collective interest lies in improving the global capacity to prevent, respond to, and overcome pandemics. Thank you, Chair.
Thank you. And now to Argentina, to be followed by Colombia.
Gracias, señor presidente. Argentina toma nota y agradece los informes.
Argentina takes note and is grateful for the reports. We'd appreciate it if reports such as that published by the IPPR could be published earlier so that we would have time to study them. But we nevertheless will look at the interim progress report and send in our relevant comments. We share the view of the importance to learn lessons from the pandemic response, and we've shared information about the Argentine experience with the IPPR, underscoring the efforts made to improve national capacities for intersectoral coordination and the whole-of-government approach, and initiatives at national and subnational level, implementation of public health measures, and the exchange of genomic information with others. As we said earlier, the COVID-19 pandemic has made it clear of the need to put the IHR at the very top of the UN agenda on meetings where heads of state participate so that we can facilitate its implementation. We're grateful for the report of the IHR Review Committee, and Argentina agrees that we don't need to change the IHR, but just strengthen its implementation. With regard to the graded alert system, we don't believe it's worth making it more bureaucratic. and it's already quite a complex system. That's why we need to avoid that. And we think that any modification should actually give it more clarity in that respect. We wonder if all of the review procedures taking place within the organization are not creating duplication of work. And we wonder if strategies could fill these organizational gaps and gradually adapt resources to the development needs of each country. Finally, it strikes us that in document EB 14818, paragraph 12, there's a reference to a European Council proposal for a treaty, which has yet to be shared with other member states. And that means it's impossible for us to comment on such an important issue. And we look forward to the recommendations coming out of the next World Health Assembly in May. Thank you.
Thank you. And now to Colombia, to be followed by Australia.
Thank you, Chair. Agradecemos al director general por el informe presentado sobre preparación y respuesta frente a emergencias de salud pública y encomiamos el trabajo de la Organización Mundial de la Salud al apoyar a los países durante el periodo que comprende el informe, no solo en materia de la pandemia por COVID-19, también con aquellas emergencias que exigieron una respuesta por parte de la organización durante el último año. En cuanto al COVID-19, consideramos que la labor que ha hecho la organización ha sido clave para los países en la formulación de planes de respuesta y mitigación del impacto de la actual emergencia sanitaria. Somos conscientes de que la articulación de los Estados miembros con la OMS es fundamental para seguir preservando la vida de nuestros ciudadanos. Asimismo, hacemos un llamado a la organización para redoblar los esfuerzos y el apoyo brindado, teniendo en cuenta el incremento considerable de casos de COVID-19 en nuestros países y a la aparición de nuevas variantes del virus. Al respecto, consideramos fundamental toda la información que se pueda recopilar por parte de la OMS en materia de emergencias, así como a través de los comités y mecanismos de examen activos en el marco de la COVID-19, con el fin de dictar medidas de fortalecimiento de los sistemas de salud nacionales basados en evidencia científica y en lecciones aprendidas. Por lo anterior, sugerimos la realización de un informe sobre la gestión regional de emergencias que contribuya al intercambio de experiencias y buenas prácticas. Respecto al informe sobre el fortalecimiento de la preparación y respuesta de la OMS frente a emergencias mundiales, tomamos atenta nota de la necesidad de avanzar colectivamente con todas las herramientas que permitan mejorar la preparación frente a emergencias sanitarias, el intercambio de información en el marco del RSI, el desarrollo homogéneo de las capacidades nacionales, el fortalecimiento de la capacidad de laboratorios y el control preventivo de la escasez de insumos médicos y otras tecnologías de la salud son temas de gran relevancia para Colombia. Nuestro país está listo para participar en los procesos de consulta y de discusión sobre las diferentes medidas a adoptar en el fortalecimiento de la preparación y respuesta de la OMS, de las regiones y de los países frente a futuras pandemias, tal como el examen universal de la salud y la preparación, la financiación sostenible, la gestión de la desinformación y demás. Agradecemos el trabajo realizado por los miembros del Grupo Independiente de Preparación y Respuesta a las Pandemias y al Comité de Examen acerca del funcionamiento del RSI durante la respuesta a la COVID-19. Agradecemos la consideración que han tenido sobre las recomendaciones y comentarios presentados por los Estados miembros y los animamos a continuar compartiendo estos informes internos, los cuales presentan valiosos insumos para la discusión sobre el fortalecimiento de la organización y del reglamento sanitario internacional. Para finalizar, agradecemos a la Unión Europea por la resolución presentada y acordada entre los Estados miembros sobre el fortalecimiento de la OMS, la cual permite avanzar de manera conjunta en esta discusión. Queremos resaltar que debe primar el espíritu colaborativo, cooperativo y solidario de todos los Estados miembros, avanzar en el fortalecimiento de una estructura mundial de prevención, preparación y respuesta a emergencias sanitarias mundiales. Thank you, Chair.
Global health emergencies. Thank you very much indeed.
Thank you very much. And now to Australia, to be followed by the United Kingdom.
The COVID-19 pandemic had an unprecedented impact on the world's health systems. Our global architecture for health emergency preparedness has been tested and found wanting. A step change is needed to meet current and future health crises. The independent evaluation of the COVID-19 response and the progress reports from the Independent Panel on Pandemic Preparedness and Response and the IHR Review Committee will guide us in the collective actions we must take. Australia affirms and appreciates this important work. The panel has provided a frank assessment of the world's risk management and preparedness planning for pandemics, noting critical elements of the system are slow, cumbersome, and indecisive. Australia agrees with the panel's observations that the COVID-19 pandemic must be a catalyst for fundamental and systemic change in preparedness. We look forward to detailed recommendations from the panel about how to organise collective global action, as well as country and regional reforms to address these deficiencies. While there may be some quick fixes, reform efforts will require a comprehensive and systemic approach. Our work ahead of the World Health Assembly will need to reflect this. Australia affirms the need for an independent and authoritative WHO and strong WHO operations, particularly in emergency response and at country level. We must take urgent action to reducing risks of zoonotic disease transmission through an enhanced One Health approach. We note the WHO Director General's comment during PBAC about strengthening the One Health concept. A strategic plan fully integrating UNEP into these efforts is needed. We agree with the IHR Review Committee that effective implementation of the IHR requires sustained political will, leadership and prioritisation based on health systems that provide accessible care to all. Australia remains a strong supporter of consistent international health emergency arrangements and an active participant in the IHR monitoring and evaluation framework led by WHO. It's important we work together to ensure the IHR continues to strengthen so as to be fit for purpose for the future. We view global cooperation as the key mechanism for enhancing global health security to prepare for and respond to emerging health threats. We note the preliminary findings to date and remain open and receptive to the need for additional recommendations as the review work continues. The WHO plays a fundamental role in coordinating and supporting the global response to health emergencies. Ultimately, member states must work together to ensure global systems are in place for preparedness, prevention, detection and response to health emergencies, and to strengthen their own national health systems to the greatest extent possible. Despite the broad range of activities WHO has undertaken across a number of health emergencies, the critical need for a more responsive and better resourced WHO remains. We must maintain a sense of urgency and ambition for reform. Australia will continue to actively support and engage in the panel's work. Thank you.
Thank you. We are mindful of the time difference for many of our member states, so thank you. And now to the United Kingdom, to be followed by the Russian Federation.
Thank you, Chair. I speak on behalf of the delegations of the G7 and Australia and the Republic of Korea. Thank you to the chairs of the Independent Panel for Pandemic Preparedness and Response and the IHR Review Committee for their updates to the board and their interim reports. Although due to the timing of the papers being released, it wasn't possible for us to make detailed remarks on them here. The G7 greatly values WHO and the crucial leadership and coordination role it plays in global health and in steering the world's response to public health emergencies, especially at this difficult time. We also recognise that there is a need to strengthen and reform the WHO to ensure it remains fit for evolving challenges, including with the continued strong support and involvement of its member states and the international community. The global health architecture also needs to increase its focus on preparedness and response to health emergencies, as well as building more resilient, quality and inclusive health systems with a view to achieving universal health coverage. The G7 supports the decision on emergency response submitted by the EU. We therefore welcome the work of the review committees with their mandates from member states and look forward to their recommendations to the World Health Assembly in May, which we need to be ambitious, grounded in robust evidence, and with clear prioritised areas for action. Some of the issues that the review processes are examining have been discussed before, including improving IHR compliance through a stronger member state-led review process and monitoring framework alongside a more consistent evaluative system that can accurately assess national IHR capacities. Elaborating the process of independent epidemiological assessment on site and prompt information sharing, including samples of pathogens when outbreaks occur, especially in the initial phase, in close collaboration with the relevant national government. Fully integrating a One Health approach to better prevent, detect and respond to zoonotic health threats. Greater clarification of roles and coordination among member states and the wide range of international organisations involved in response to pandemics, including in case of cross-border movement by sea or air, and finding sustainable financing approaches which allow for WHO to fulfil its core mandate within the global health architecture in an effective, efficient and strategic way. Some changes do not have to wait for these reviews. There are areas that WHO already has started to work on or could advance in the shorter term. For instance, strengthening communication around the decisions of the emergency committees, setting up of the One Health High-Level Expert Council by WHO, jointly with FAO, OIE and UNEP, in coordination with relevant initiatives, including the One Health Global Leaders Group in antimicrobial resistance, facilitating greater access to global public health intelligence to support countries and global organisations with timely and actionable intelligence, implementing the recommendations on management of the WHO Health Emergencies Programme as recommended by the IOC, establishing the groundwork needed to fully implement an early warning or intermediate public health alert system as part of the fake declaration process based upon previous IHR Review Committee recommendations, enhancing WHO's normative role and guidance on handling health emergencies, indirect health and socio-economic impacts, and maintaining essential health services, providing clearer and more updated guidance on travel and trade restrictions and their impact in order to avoid unnecessary harm to economies, working with other relevant international organisations, and improving member state engagement in public health emergencies, including by strengthening the role of this executive. We must use this existing momentum to make these urgently needed changes happen. We therefore have high expectations for these reviews and look forward to closely looking at your recommendations. And to WHO, our message is that we stand ready to work with you and other member states to strengthen emergencies response. Thank you.
Thank you. And now to the Russian Federation, to be followed by Germany.
Уважаемый господин председатель, Российская Федерация.
Chair, the Russian Federation welcomes the work done by WHO on combating emergency situations related to health, in particular in the context of the spread of the novel coronavirus infection, the pandemic. The pandemic has been a serious test for national health systems in all countries. It has revealed problems of preparedness and response at global level. It's impossible to ensure epidemiological well-being in one country alone. The basis of protection from infection has to be collective capacity at regional and global levels. Russia supports the central coordinating and leadership role played by WHO in international efforts to protect public health from the threats of epidemics of infectious diseases, including through the introduction of the IHRs. We think that it is not acceptable to create mechanisms that duplicate the functions of WHO and undermine its coordinating global role when it comes to combating epidemics. We do not see any need to revisit the IHRs. The priority, rather, is to improve the mechanisms for introducing the IHRs in practice, including by providing support to countries that need it for capacity building in order to allow them to implement the IHRs. We also need to include methodological and advisory support for national coordinators, and we need, on the basis of the principle of multilateralism, to improve the mechanisms and the regulations for conducting reviews of IHRs. As well as that, we need to improve the work of the emergency committees created within the framework of the IHRs. We wish to emphasize the importance of creating conditions for the implementation of the IHRs as an instrument for developing health systems and protecting public health. We think that it is not acceptable to try to use the IHRs to exert pressure on countries in order to control or monitor their capacity when it comes to biosafety and epidemic response. We need fully to respect the sovereignty of member states. We are categorically opposed to the introduction of a mandatory mechanism for external evaluation of the IHRs. This is a general stance that is taken by all countries within the Eurasian Economic Union. What is particularly important when it comes to developing WHO's capacity for preparedness and response to health emergencies is that we have recommendations from the corresponding expert bodies that have a mandate from member countries, in particular the Review Committee on the Functioning of the IHRs during the COVID-19 response. We wish to draw attention to the provisions of the document supported by the committee relating to the exchange of information between individual countries and WHO. We also wish to note that the conclusions and findings of the committee must be objective and unbiased. We wish to support the appeal to develop for the 74th WHA a resolution on the issue of capacity building for WHO on preparedness and response to global health emergencies. And we stand ready to play an active and constructive part in the work on that in cooperation with all other member countries. Thank you.
Thank you. And now to Germany, to be followed by Finland.
Thank you. Germany aligns itself with the EU statement delivered by Austria and with the G7 health statement delivered by the UK. Germany likes to express its thanks to the IPPR, the IHR Review Committee, the Independent Oversight Advisory Committee, and the Global Preparedness Monitoring Board. We deem your work highly essential to learn from the greatest global health crisis of our time. Two things were true before COVID-19 appeared a year ago, and they remain true even once we will have overcome this pandemic. First, it might not be clear when and how the next global health crisis will strike us, but it is clear that there will be a next one. And second, among others, the international structures to prevent, detect, and respond to such a pandemic have proven to be insufficient to prevent the greatest global crisis of our times. COVID must be understood by all of us as a turning point for global health and global health security. President Sirleaf, you rightly called for a reset. We must be willing to do everything to ensure that this never happens again, and that we are truly prepared for the next global outbreak of such a dimension. This calls for our common responsibility and investment in global health preparedness. To defend the status quo or to only implement the so-called low-hanging fruits cannot be an option. We have to rethink how we are doing business. We have to overcome our common comfort level if we want to be successful. COVID might be the greatest health crisis in recent times, but as others before us have said, there were many others before, like the Ebola crisis in West Africa just 5 years ago. All these health crises also created lessons learned processes which produced recommendations in order to prevent similar crises in the future. Out of these roughly 200 recommendations coming out of these more recent lessons learned processes, only 10 have been implemented, mostly only partly, and mostly the so-called low-hanging fruits. Colleagues, we do not have a lack of recommendations to make the world less vulnerable to global health crisis. We do have a lack of common political will among 194 member states to learn from past mistakes and to implement these recommendations. Coming back to our indeed high expectations vis-à-vis the four panels, we hope and expect from you not less than that you are pushing us 194 member states to overcome the insufficient status quo of global health preparedness and to fully implement bold, ambitious, and truly needed improvements in global health preparedness. Because the world cannot afford to experience such a global health crisis again in the future. I thank you.
Thank you. And now to Finland, to be followed by China.
Okay.
That's okay. When you're ready, thank you.
Okay. Sorry. Chair, Finland aligns herself with the statement made on behalf of the EU and its member states. We thank the Independent Panel for Preparedness and Response, the IHR Review Committee, as well as the Secretariat for their reports, and the IOAC and GPMB chairs for their updates. We appreciate the openness of working methods and regular communication on these important issues. 1 year ago, the 146th Executive Board adopted a resolution on preparedness, which was adopted also by the World Health Assembly in November. The inadequacy of the world's preparedness efforts has become devastatingly clear. The resolution called for investment in key public health functions as a basis for preparedness and sustainable response. Strong and resilient health systems and the continuation of provision of essential health services are critical during the crisis. The importance of gender response approaches and the engagement with communities also become clear. Many of these themes discussed a year ago emerged across the interim reports received for the consideration of the board. We look forward to the IHR Review Committee's assessment of potential changes needed to existing instruments, for example, in relation to public health emergency of international concern and access to pathogens. The pandemic highlights the importance of strengthening cooperation across sectors of society and promoting the health of humans, animals, in the environment. Yesterday, we noted the work planned by the Secretariat in establishing a One Health high-level expert council. One Health collaboration is a long-standing practice in Finland. The IHR monitoring and evaluation framework has helped countries to gain an understanding of the level of their IHR core capacities and to exercise their functioning, as well as to strengthen multi-sectoral ownership. The joint external evaluations have promoted open sharing of information about preparedness among peers in a constructive way. The lessons learned so far can provide valuable basis for further improvement of the IHR monitoring and evaluation, in particular as the functionality of the preparedness arrangements. Importantly, we have to better understand how countries can ensure appropriate resources and political leadership and commitment to strengthening preparedness. Going forward, the development of more permanent and inclusive platforms for cooperation, innovation, and delivery will be essential for the rapid response to evolving health threats. Finland echoes the consistent message by the previous committees and by the current evaluation groups. Investing in preparedness is a necessity and a lesson we cannot afford to overlook. Thank you.
Thank you, Finland. And now to China, to be followed by Oman.
阿曼做准备。Mr. President, China appreciates the work done by IPPR, which is headed by President Sharif and Prime Minister Helen Clark, the IHR Review Committee, and the IOAC. The IHR 2005 is a legal cornerstone of global public health security. China firmly supports responding to international public health emergencies within the IHR framework. China has noticed the interim progress report submitted by the Review Committee and the overall assessment of the report. We have also taken note of the problems and challenges in relevant provisions and the implementation process of the IHR that were exposed during the COVID-19 pandemic. China supports updating and refining the IHR so that the world can join forces in the fight against the pandemic. This is the common interest of the international community. Facing the unknown SARS-CoV-2, China immediately notified WHO of the epidemic situation, shared the virus genome sequence at the earliest possible time, and took the most comprehensive, thorough, and strict prevention and control measures. All of the efforts bring significant strategic results. China wishes to draw your attention to the fact that the statement mentioned in paragraph 25 of the report, that the communication between the State Party and the WHO Secretariat may lead to delay. That is inconsistent with facts and fails to fully and truly reflect the fact that China communicated with the WHO between January the 1st and the 3rd, 2020. Second, China actively supports working in the IPPR and provides the group with a detailed timeline of China's fight against the epidemic, as well as a large number of documents and materials such as epidemic prevention and control, treatment plans, measures, policies, and relevant papers. However, we regret to note that paragraph 29 and 30 of the report are not in conformity with the facts. Since Wuhan reported pneumonia of unknown origin, Wuhan, Hubei Province, and China National Health Commission enlisted experts to study and analyze the situation comprehensively from different aspects, including disease symptoms, treatment, epidemiological investigation, and laboratory testing. While the pathogen was still unknown, the public was advised to avoid enclosed, unventilated, and crowded places. Wearing masks was also recommended for going out. Wuhan closed the Huanan seafood wholesale market on the 1st of January 2020. All these efforts were extraordinary public health measures taken under the circumstance where the pathogen was still unknown and the virus virulence and transmissibility was still unclear, which was precious time for China and the world to fight the virus. I would like to point out that we cannot use our current understanding of the virus and the pandemic to judge the situation of the early days, which goes against our common sense for learning and understanding the unknown. On January the 23rd, 2020, when only 4 countries outside China reported 7 cases, China announced public transport control in Wuhan and pressed the pause button for Wuhan, a city with a population of over 10 million. That was a resolute decision which was not taken lightly, but we did it. And we made huge sacrifices for global fight against the virus. That has gone way beyond the traditional public health measures. We urge the international community to look at China's anti-epidemic efforts from a rational and scientific perspective. These extraordinary and forceful public health measures are immense contributions that China made to the world. China suggests that the review committee and the IPPR should further improve the report and make scientific, objective, fair, comprehensive, and balanced assessment from both prevention and response. China calls upon all countries to show their positive will to support the panel to carry out the assessment work. Also, we would like to call upon all countries to pay attention to several concerns, such as the fair distribution of vaccines. China would like to make more contribution to the common interest of the international community of common health. Thank you.
Thank you. And now to Oman, to be followed by Austria.
جزيلا سيدنا. قامت سلطنة عمان بمتابعة الأوضاع.
Sultanate of Oman has been following closely the epidemiological situation with COVID-19 since January, and we have dealt with the pandemic on several levels through the government, where a higher commission was set up where across the various sectors, and the principle was to enable the health services to cope with the pandemic without impacting other health services. There was constant efforts to ensure that communication is appropriate, that the press is on board, that all actors are involved in the process, and to ensure that government services are provided at all times. We have also embarked on a policy to ensure that when a vaccine was ready, it would be available to all citizens. We responded to the situation with equality and fairness in our mind, whereby Omani nationals and residents in the country enjoy the same privileges, and that's how we decided to respond to the pandemic. We would like to reiterate our commitment to helping WHO as a leader in the process and in dealing with emergencies. We are committed to exchange of information, data, and all relative studies to pandemics and vaccines. The Sultanate underscores the importance of ensuring an equitable distribution of all vaccines at all levels. Thank you.
Thank you very much. And now to Austria, to be followed by the United Kingdom, who will be making national statements. As we understand, the earlier statements were joint regional groupings. Thank you. And Austria, you have the floor.
Thank you. Austria aligns itself with the statement on behalf of the EU and its member states. We commend the excellent work of the 3 review committees and welcome the report on WHO's work in health emergencies. There are already so many points made to be picked up for next reform steps. We are looking forward supporting these proposed measures. Early risk communication and information sharing on public health events and international spread is fundamental for effective preparedness and response measures on a national level. Considering the speed and impact of social media, effective and timely communication between the WHO and the member states becomes even more important. Having this in mind, more transparency with regard to the criteria on the declaration of a fees is necessary. Clear criteria would allow consistency in the decisions of the emergency committee and could enhance the support and understanding of the decisions from the member states. The criteria and underlying evidence for a fees should be made available to the member states in a timely and transparent way. We welcome the discussions on a possible intermediate level of alert, but clear criteria on its introduction should be explored in more detail. An intermediate level of alert as an initial warning signal could speed up communication and allow early action for strengthened preparedness and rapid response in accordance with raising awareness on national level. The consequences of declaring an intermediate level of alert should be part of further discussions. Thank you.
Thank you. And now to the United Kingdom.
Thank you. Further to our remarks on behalf of the G7, we have some additional comments to make on the papers in our national capacity. Firstly, we thank the review teams and chairs for their pragmatic and helpful observations. We're pleased to see reflections on updating the early warning system to become more nuanced and modernised, the transparency of the emergency committee, and on the universal health and preparedness review pilots. We agree that the role of the IHR national focal point should be strengthened, and with a focus on enhancing the existing IHR framework. The UK remains committed to supporting countries to achieve full compliance with the regulations, and more broadly, we encourage the review chairs to work closely with the regional committees and officers who have important insights to share also. The field mission of the international experts to Wuhan is an important part of the investigation into the origins of the SARS-CoV-2 virus. The investigation must be open, robust, and scientifically rigorous to ensure that lessons are learned for future pandemics. We look forward to hearing further updates as the work progresses. Finally, we emphasise WHO continuing efforts to strengthen the operational and administrative resilience of the overall health emergencies programme, not only for pandemics, but as WHO continues to respond and to lead in several other complex emergencies. This includes fully implementing the full breadth of IOC's recommendations over recent years, ensuring strong leadership in the most complex contexts, further developing recruitment and administrative capacity, and ensuring conflict sensitivity and a relentless focus on safeguarding staff and communities. Thank you.
Thank you. And now to the last two statements by members of the Executive Board, the Republic of Korea and followed by Chile. Thank you.
Thank you, Chair. We would like to express our gratitude to the IPPR, the IHL Review Committee, and the IOAC, who made dedicated effort since launch to conducting reviews based on scientific evidence and objectivity with their mandates from the member states. We anticipate that the final recommendations of each committee will become a clear guideline for the actions that member states should take in the short to long term. Moreover, the Republic of Korea will continuously offer our full support to ensure there are no setbacks to the three committees' work. An early detection of a possible PHEIC event and notification to WHO must be promoted by member states. To this end, surveillance required by the IHL, particularly the establishment of evidence-based surveillance system and the strengthening of diagnosis capacity, as well as the function of the national IHL focal point, is very important. Notably, the current information asymmetry we are witnessing between member states with regards to the function of the national IHL focal point should be improved based on the recommendations of the IHL Review Committee in the future. In January 2020, the Republic of Korea notified the WHO when an imported case of COVID-19 was confirmed through the early detection and diagnosis. To date, we have been detecting COVID-19 cases at an early stage through large-scale tests and reduce transmission as much as possible through constant tracing. In addition, we have been continuously sharing information on the current status with UPRO and our experiences with the international community. Our current discussion on the improvement of IHL will serve as a stepping stone for WHO's effective and proactive response to future global infectious disease based on the lessons we learned from COVID-19 pandemic. In this respect, the Republic of Korea would like to extend our sincere appreciation to the G4IDR core group for their past commitment to discussions. We would like to express our support for the G4IDR joint statement and ask the member states for their keen interest. Finally, the Republic of Korea conveys our support for the G7 joint statement on the activities and role of IPPR, IHL Review Committee, and IOAC. And we will continuously engage in discussions with the Secretariat and the member states on matters requiring longer-term reforms, including a full integration of One Health approach and sustainable financing. Thank you.
Chile agradece el informe.
Chile wishes to thank the Director General for the report, and we thank the Secretariat for the work in organizing this session of the EB in remote format. The COVID-19 pandemic has changed ways of working, and it's gone further than that. It's changed our lives and the way in which we live together. And in that background, we welcome the capacity to change within the WHO and the capacity to respond to the challenges that have arisen. And we reiterate our commitment to contribute to global efforts to combat this pandemic. And indeed, to work to guarantee healthy lives and well-being for all throughout the life course. At this very difficult time, the work of the WHO is even more important. The whole of the world has seen how important it is and has put efforts into developing vaccines and rolling out vaccination. This spirit of cooperation must remain in the context of the ACT Accelerator and the COVAX facility for promoting vaccine availability. We also welcome the work being done by WHO in meeting the resolution on COVID-19 adopted by the WHO at its 73rd session, and the review procedure of WHO's response to COVID-19. Our country, Chile, sincerely hopes that this process will strengthen the WHO and will lead to tangible measures to ensure that in the future the country's response and the WHO's response are even faster and more effective. As we come to the end of our role as a member of the EB, we would just like to reiterate our commitment to multilateralism and proposals to improve the response of our country to COVID-19 have been well received and taken in a very collaborative spirit. And we thank the WHO and the other countries in the region for their efforts to support us in this task. Chile has, at all times within the EB, tried to promote the importance of the issue of healthy aging. It's a multidisciplinary task, and our First Lady has been carrying this fight forward within Chile. The pandemic has just underscored the vulnerability of the elderly, one of the most affected groups. And in our country, we believe very strongly that the Decade for Healthy Aging, 2021-2030, adopted by the WHO, and indeed adopted recently by the UN, will make a useful contribution to ensuring that the elderly have better and more healthy lives for longer. We reiterate our commitment to continue to work to achieve global health objectives and to ensure healthy and longer and happier lives for all throughout the life course. Thank you very much indeed.
Thank you very much. We shall now move to statements by those member states not represented on the board. I should wish to give the floor to the distinguished delegate of Japan, to be followed by Pakistan.
Thank you, Chair. We appreciate IHL Review Committee, IOSC, IPPR, and GPMB to report their findings. Japan co-sponsors the decision proposed by EU at the EB 148, WHO's work in health emergencies, strengthening WHO's global emergency preparedness and response. Especially regarding IHL, some questions about the current regulations and the operations of them were raised. Bearing these in mind, to prepare better for the next pandemic, in line with promoting universal health coverage, I have 3 points to raise. Firstly, the member states need to ensure and strengthen the role and the functioning of IOSC as a legitimate oversight body for WHE. Secondly, the member states should consider strengthening networking and early reporting mechanisms during crisis-free times to enable swift initial response. Thirdly, it is important to strengthen surveillance capacities during crisis-free times, including collaboration with member states and regional crisis management centers. Taking this opportunity, I would like to present relevant development on global health in Japan. Recently, recommendation on strategic expansion of international collaboration scheme and Health ODA have been submitted, which was created at the public-private committee consisted of Diet members and technical experts in Japan. Based on this recommendation, Japan is committed to contribute to the health for all people in the world through more effective and intensified international collaboration in health, including contribution to the reform of the global health framework, which emerged from the response to COVID-19. The intended contribution includes promoting UHC at global level through strengthening quality, resilient, and inclusive health system and sustainable health financing, and also through strengthening multi- and bilateral cooperation with a consistent strategy. Thank you.
Thank you. And now to Pakistan, to be followed by Zambia.
Thank you, Madam Moderator, Mr. Chairman, and honorable delegates. Pakistan has noted the interim report of the IHR Review Committee and appreciates the efforts of the WHO and its relevant committees in this regard. The COVID-19 pandemic has revealed systemic gaps and vulnerabilities in health systems globally vis-a-vis pandemic preparedness and response. It has also shown that how quickly any new virus can sweep away the decades of hard-won social and economic gains. The interim report of the IHR Review Committee also identifies important pointers related to states' capacities, early warning, and methodology of determining a public health emergency of international concern. The Review Committee must focus on minimizing all factors that can cause delays, as pointed out earlier by the Chinese delegation. Pakistan sees COVID as an opportunity for the world to translate this pandemic as a catalyst for a lasting and systemic change in preparedness for better responding to future incidents. There is indeed a renewed realization that more decisive and effective steps may be taken for developing IHR core capacities. Mr. Chair, the existing level of collaboration and assistance needs to be scaled up and aligned with the national efforts meaningfully for all countries to develop strong, resilient, and integrated health systems. We believe that any discourse on IHR must embed the focus on technical assistance, financing, and capacity building to allow developing countries to achieve their public health goals. It is also important to ensure that the COVID-19 vaccine is distributed early and equitably to everyone. Healthcare workers and older people are the priority in all countries, rich or poor. The advance purchase agreements should by no means deprive the developing countries from getting equitable access to vaccine. This is a real test of international solidarity, and we thank WHO for its consistent advocacy for the purpose. No one is safe until everybody is safe. I thank you.
Thank you, Pakistan. And now to Zambia.
Thank you, Chair. Zambia aligns this statement to that made by Botswana on behalf of the Africa region. Chairperson, Zambia commends the efforts highlighted in the reports, especially the ACT Accelerator in general and the COVAX AMC facility in particular, the CETAP and the GPMB initiatives. As the Director General rightly observed in the report, we, however, still experience inequities even amidst the progress made, particularly among the most vulnerable members of our society. As is the case with many African countries, Zambia has experienced an upswing in cases and deaths from COVID-19, more especially with the second wave, underscoring the importance of ensuring the COVAX AMC facility attains the purpose for which it was established. We end by recognizing the efforts of the Secretariat led by the Director General in supporting member states and applaud their commitment to redouble efforts in the ongoing impartial, independent, and comprehensive evaluation work of the review committees on the functioning of the international health regulations during the COVID-19 response, the Independent Oversight and Advisory Committee for the WHO Health Emergencies Program, and the Independent Panel for Pandemic Preparedness and Response. In this regard, Chair, Zambia supports the draft decision introduced by the EU and its member states and requests to be included on the list of co-sponsors. Thank you.
Thank you very much. I understand that we have come to the end of discussions for today. There are still requests from around 30 participants, including 9 non-state actors. However, I should like to hand back to Mr. Chair, the Honourable Minister of Health from India. Thank you. You have the floor.
Thank you. I understand that we have come to the end of today's session and that one delegation has requested the opportunity to exercise the right of reply in relation to statements provided under 2 of the items which were discussed today. I would now like to hand the floor to the Vice Chair, who is present in the Executive Board room to facilitate this portion of today's discussion on my behalf. Mr. Komal, you have the floor, please.
That the delegation of China would like to take the floor to exercise the right of reply. In delivering a right of reply, delegations are requested to be as brief as possible. I hope delegations will understand that this request is made in our common interest in the good order of our proceedings. I shall now give the floor to China. China, you have the floor.
Thank you, Vice Chair. Vice Chair, Taiwan is an integral part of China. This is a consensus shared largely by the international community. UNGA Resolution 2758 and WHA Resolution 251 provide the legal basis for WHO to respect the One China principle. However, during this meeting, which should put focus on the fight against the pandemic in solidarity, one representative chose to abandon this consensus and insisted on formulating a responsible statement challenging the One China principle and undermining the global collective efforts to fight against the pandemic. China protests and firmly opposes to this. The question of the China region participating in international organizations' activities should be guided by the One China principle, and proper arrangements should be made through cross-strait consultation. The Taiwan authorities refuse to accept the One China principle. The political foundation for the Taiwan region participating in WHO therefore doesn't exist anymore. China's central government attaches great importance to Taiwan compatriots' health and well-being, and proper arrangements have been made for the Taiwan region to participate in related activities. Since the outbreak, cross-strait channels and technical exchange channel between the Taiwan region and WHO have always remained open. The epidemic situation in the region shows the arrangements made are reasonable and effective, and there is no so-called gap in the epidemic prevention and control. There are also channels and platforms where experts in the Taiwan region present their prevention and control work. Few individual countries hyping up the question of the Taiwan region participating in WHO has the true intention to create 2 China or 1 China, 1 Taiwan. Their attempt will not succeed. China suggests these countries to put more efforts on epidemic prevention, control, and saving lives, and to shoulder their share of responsibility towards the population and in international community. Confrontation and division deemed to be unpopular. Solidarity and cooperation is the only way out. I thank you, Vice Chair.
Thank you, Mr. Komal. I would now like to close today's meeting. Thank you for the good progress and productive discussions today. We shall reconvene tomorrow at 10 a.m. Central European Time and continue with item 14.2. I bid you a good morning, good afternoon, and good evening.